there, yeah.
I can't figure out someone you sent me. I've gone into that. I'm a Mac user.
Yeah, no. Let's get rid of that.
I mean, I just got that from one of the slides.
Yeah, let's go. We'll make it. Did they want it so?
No, I just thought it might be nice.
Yes, yeah. That's all right. That's all right. Where is the picture? Now, where did we are?
The picture, that link picture.
Yes.
It's on the desktop.
It's on the desktop. Cool. Get rid of this. So we'll make it black. Hopefully.
I was going to try making it full screen when you open the file.
Yes. Yeah, I know exactly what you're doing, but
It doesn't seem to be the same.
it's too low quality, unfortunately.
Okay.
It's on the desktop.
It's called Hold. Yeah.
So, where's the first speech? Which is the first?
Intro, I think. Yeah, link. Yeah.
Cool.
So I just copied that. Yeah, I was originally going to do that.
Let's do that. Oh. No, you don't do it for that yet. I've done this speed for a while. Cool, yeah, because it's just low quality, so what we'll do is centre it up and then go F5.
Hey,
Just low quality. There's not much more we can do about it.
Right. Well, good afternoon, everybody. It's my great pleasure to welcome you here to the Royal Society in London for an afternoon in which we're going to hear about a DFID-supported initiative called the LINK programme. The title is Data for Targeted Malaria Control Interventions. Are we there yet? Now, it's a particular pleasure for me to be here at this juncture because I was involved right at the beginning of the programme when I was based at the London School of Hygiene and Tropical Medicine, working with colleagues in Kenry Wellcome in Nairobi to pull together what we thought and DFID thought would be a useful set of activities to help accelerate improvements in malaria control. So just to set this in context, at the turn of the millennium, year 2000, several different approaches estimated that there were about 1 million people dying of malaria every year. The total amount that was spent on malaria was about $100 million a year, which was about the same amount as was spent making the film Titanic at around about the same time, so it gives you a sense of the world's priorities. There was no global fund, there was no Gavi. The Bill and Melinda Gates Foundation was not yet formed. We were in a really shocking position. The pipeline for antimalarial drugs was really empty. High levels of chloroquine resistance, high levels of sulfadoxine pyrimethamine resistance. It all seemed rather hopeless. But at the end of the 1990s, there were some signs of renewed interest. I think first in the formation of the Multilateral Initiative on Malaria, MIM, signalling interest from National Institute of Health in the United States to really get involved in malaria. Let's do something about this intolerable burden of malaria disease and death. Those institutions I just mentioned, Global Fund and the Bill and Melinda Gates Foundation, were formed to act, for instance, on the recent innovations in vector control, insecticide-treated mosquito nets. My current boss, Pedro Alonso, the director of the Global Malaria Programme at WHO, was involved in the early studies of insecticide-treated mosquito nets and recounts the story of him presenting his findings as a young, upcoming researcher to WHO, and people sort of nodded, yes, there was a strong indication that insecticide-treated nets could save lives, but the idea that nets could become a cornerstone of malaria control was thought fanciful at the time, and it took a lot more research for randomised controlled trials to demonstrate that really this was an approach to malaria control which had legs and would warrant development of the systems and the financial mechanisms to make insecticide-treated nets widely available in sub-Saharan Africa. So fast forward to 2015 or so, and we had a series of World Malaria Reports, the annual report from the Malaria Programme at WHO, showing very clearly that every year there was a steady decline in the number of malaria cases, a steady decline in the number of malaria deaths, and that investments in malaria control, and indeed in research and development of new tools for malaria control, was increasing. And we, I think, maybe as a community got a little bit complacent that we're on a good track and we just needed to keep on going. Then last December, the World Malaria Report was titled Malaria at a Crossroads, because for the first time in the last 15 years or so, there was documentation that actually this steady rate of progress had at best halted and in some cases reversed. So this was a little bit of a wake-up call. We suddenly find that the investments in malaria control have plateaued, around about the $2.4, $2.6 billion mark, so a massive step up from where we were in the year 2000. But still that represents around about 40% of the estimated total cost of optimising malaria control with the tools that are currently available. So stagnated levels of investment mean stagnated levels of coverage of key interventions and a halting and, as I say, a reversal of the progress in malaria control in at least some countries. So as that story's been unfolding, the LINK programme has been working since 2014, I think, to make better use of data which already exists, collate available information, bring it together, and present it in ways that can help to inform discussions at the national level about operational decisions that need to be made to improve malaria control. How can you make the best use of the available resources? And I think the LINK programme this afternoon, we're going to hear about many of the activities. I think we're really going to focus on lessons that have been learnt, not all the triumphs. You've seen hopefully the posters outside and the reports of the malaria profiles from a whole number of countries. But we're going to think about the lessons that have been learnt through the course of this work, because I think it's fair to say that this work will be feeding directly into a new initiative led by the World Health Organization's Global Malaria Programme to do better with the resources that we've got available. People have been referring to this as a 10+1 initiative, trying to maximise the public health impact of the resources available to invest in malaria control. And one of the cornerstones of that work relates to deep analytical approaches at the country level to really get a handle on where malaria risks are highest, which interventions need to be targeted. So this comes at a perfect time, as far as I'm concerned, as I'm now based at the Global Malaria Programme, to understand really what are the remaining challenges. What do we need to be mindful of as we move forward in this new era, where I hope and pray we'll see renewed engagement and investment and commitment to the fight against malaria. If there's one thing that the last 15 or so years have shown us, it's that if you invest in malaria prevention and control, you will save lives. It's really very, very clear. It's excellent value for money, and we certainly applaud DFID's investment and long track record of investment in malaria control over the decades. But this afternoon we need to know now really what can we do moving forward to build on what we've learned in LINK and maximise impact with public money. So the format of the afternoon is really a series of presentations. I hope everybody has the schedule in front of them. Caroline Lynch, who is the leader of the LINK programme, will give us an overview of what it's all been about. We'll hear from Imelda Okiro on the technical aspects of the mapping malaria risk and a view to the future. And then we'll also hear from Jane Webster on the challenges of using evidence to inform decision-making and to target interventions. There'll be a break when we'll then switch perspective more to the country level. So Damien Rutizana from the Ugandan Malaria Control Programme will talk us through the processes used in decision-making in Uganda, recognising that actually, the idea of having to make decisions about how you invest the resources available is nothing new. This is something that malaria control programs have had to deal with since time immemorial. But now what we're looking to do is to try to ensure that such decisions are supported by whatever evidence is available, to try to ensure that the decisions that are made about resource allocation are as rational as possible. Then Kate Kulizinski is going to talk about the Global Fund's perspectives on targeting, stratifying, prioritising interventions. Then we'll hear about one approach, health technology assessments from Francis Reyes from Imperial College. And then lastly, in the presentations, we'll finish with Justin Parkhurst talking us through some insights to the political economy of decision-making around malaria control. So that's a fairly extensive list of presentations. I think everybody's got 20 minutes or so to not only present but also take some questions. I'm instructed that after the break we will be having a panel discussion, so we'll ask some of the speakers to come and sit up at the front, and we'll have a moderated discussion there. We can pick up on any questions that come up that we don't have enough time to discuss after the individual presentations. And we'll aim to finish promptly at 5 o'clock so that we can join a reception just outside and continue the discussions over some refreshment. So without further ado, let me welcome Caroline to come and talk to us about the LINK programme, Better Decisions for Malaria Control.
Hello, good afternoon, and welcome to everybody. Just so that you're aware, we are streaming live, so I'm also welcoming people who are watching online from various other places. My name is Caroline Lynch, and I was leading the LINK project for the last 4 years. This really is our wrap-up symposium, and as David said, we want to focus on the lessons that we've learned, really to try and move things forward and hopefully evolve into better decisions or improved decisions for malaria control. So just to explain, our LINK project is actually two groups of, or two organisations. One is the London School of Hygiene and Tropical Medicine, and the second is Kemri Wellcome Trust, based out of Nairobi. And you'll hear from Imelda from that group after me. And together we are the LINK project. And so I'll start from the bottom of this slide and move upwards to explain the context within which we were working. So our role was to try and make evidence available and accessible to national malaria control programs. We would collate data, model it, and then disseminate it to the programs and with the programs. But we were just a small cog, really, of a much larger regional program run out of Brazzaville by the World Health Organization African Regional Office. And their role was to strengthen systems for generating good quality data, and that was mainly routine health information data, compile that data, and then work with national programs again to translate that into knowledge and into decisions. So just to go into the LINK side of this, our focus was on 13 of the highest burden countries. Obviously, Afro had a much more extensive focus than us. And we were looking at prevalence data. So more recently, in the last few years, you'll have seen this shift towards improving the quality of routine data. But at that time, we were looking at prevalence data. And our rationale for that was that there was a lot of prevalence data in country that was available, either through the malaria indicator surveys, MICS, demographic and health surveys, but as well through research groups who were undertaking studies in various countries. And the idea was that if we could gather all of that together and use it more carefully, we could then look at what the transmission intensity was in different parts of the country. As David had said, since 2000, there's been a massive scale-up of malaria control interventions. And so with that improved malaria control, the thinking was that transmission intensity would reduce, but as it reduced, it would do so in a variable manner. So it would be a heterogeneous transmission that we'd see. And by being able to visualize that heterogeneity, programs could then target their interventions more effectively and more cost effectively. So as David said, just recently, this year, the Global Malaria Programme have launched the 10+1 initiative. Actually, some of our Afro colleagues can't be here because they are launching this tomorrow as part of UNGA. But I just wanted to highlight a few of the pieces that they were talking about in MPAC recently, and that was moving from blanket to granular data for action, to prioritise interventions, to have focused and tailored and intensified actions, and to change the mindset from blanket to more granular data. So the LINK project's perhaps a little bit before its time, perhaps paving the way for this more targeted approach. So I'll briefly go through how it was we thought we would effect change through our activities, our theory of change. And then I want to run through, just to highlight 3 of the main challenges that we found in undertaking the work. So starting with the activities, and you'll have seen some of our work outside, but what we aimed to do was work with national malaria control programs. We'd engage with them, talk to them about who their partners were, where we could potentially access prevalence data and also intervention coverage data, and then work with them, normally a focal point within the national malaria control program, to collate all of that data together. That isn't as easy as it sounds, but I'll get to that shortly. At that point then we would transfer that data to Kemri Wellcome Trust, and the team there would spend 2 to 3 months cleaning it up, verifying it. If there was geolocated data, they would double check all of those codes were correct. In the meantime, although we didn't use them in the prevalence mapping, they would also take the opportunity to map out or get as much information on health facility data sets and verify those for the National Malaria Control Programme. And then they would hand that back to us to then work with the National Malaria Control Programme and partners to disseminate the data and think through what the implications are for national strategic plans coming up, concept notes for the global funds and that kind of thing. Latterly, because this process of modelling is quite a burdensome process, so at the start, I mean, I think it's evolved over time, and Imelda can talk more to this, but at the start it meant modelling for 2 to 3 weeks on a survey in a server in Norway, and so it wasn't feasible at that point to have that happening at national level. But latterly the group managed to develop a desktop-based app so that then they could train some national malaria control programs to append data on and then run that app themselves at the national level. So we were kind of looking to the future and allowing programs to do this mapping themselves. The outputs, as you'll see outside, hopefully during the break, were these epidemiological profiles, timelines, and indicator posters, and we would hope a strong relationship with national malaria control programs, so that then they would feel that this is their data, obviously, and they were able to engage with it and take it up and use it for their strategic decision making. I won't go through everything on the slide, but I just wanted to highlight again our kind of more distant outcomes and impact were using evidence to target malaria control interventions. So using these epidemiological profiles and any other data that was available to then target interventions for improved value for money. This is just an example of some of the maps. This is Nigeria and Uganda. And on this right-hand side, you've got the prevalence, and then you've got intervention coverage on the left-hand side of mosquito nets. And then we would do the same for IRS, SMC, any other interventions that were being rolled out by the country. What we would try to do as well if we did a reprofile of a country was to try and show the evolution over time. So in Uganda, for example, you've got the 2009, 2014-15, so you can see the reduction in transmission intensity throughout the country and at the district level. So at the national level, they could potentially then allocate out to districts. So we had the profiles. What we also tried to do was to try and improve our relationship or the engagement with national malaria control programs. We would develop these country timelines. Again, you'll see some outside. And that process was interesting in many ways. One, because we initially saw it as an engagement tool, but two, it really highlights the amount of effort that has gone into malaria control in the last 100 years. So this is in Kenya from 1900 up until present day, all of the malaria control that has taken place there. And we would also do data use activities. So in Uganda recently, for example, we kind of forecasted or made up kind of scenarios for 2022 as to what the transmission might look like there if they were achieving their goals of the national strategic plans. And then discussing, putting all of that data together, intervention data, resistance data, vector density, for example, and getting them to think through, well, okay, what's the next decision at this point? Are there any urgent areas that we need to focus on, or where do we go from here? So again, it was about trying to get folks to use the information that we were providing them. And then what we would do is we would transfer all of that synthesized evidence now. If I think of data as the building blocks of evidence, the kind of amino acids. And then we'd transfer all of that synthesized evidence, the images, the maps, any of the reports, the papers that we had found and put into the profile were then transferred to the National Malaria Control Programme, with the idea being that that would then be uploaded to their national repositories and being supported through the WHO AFRO programme. So we were trying to institutionalize that data rather than programs then having to go and recollect all of that again at some later stage. Okay. So as David had said, we're not going to focus on the successes of the program. Rather, what I wanted to do with today was talk about the challenges and see how we could move forward from there. So I wanted to highlight 3 major challenges that we found when we were undertaking the work. And they kind of relate to the point between the activities and the outputs, and between the outcomes, the 2 outcomes and the impact. So these were data sharing, timeliness, and targeting of interventions. And when I say targeting, what I've learned in the last few days, as we've sat down with some of our colleagues, is that my definition of that is too narrow. I'm talking about optimization, rationalization, tailoring to epidemiological strata. But let me go through those one by one. So data sharing. It's very difficult. And not only, it wasn't only between, I think normally when we think of data sharing, we think, oh, researchers, they never give us their data. It wasn't just between researchers and ourselves, or researchers and the National Malaria Control Programme, but between government departments, between divisions within the Ministry of Health. It was difficult to get data. And so there's an issue about data governance, and going forward that will become more and more apparent, I think, especially as if you look at, say, the elimination countries in the south of Africa, and they're collecting individual-based data. Sharing that at a regional level then is something that could become quite sensitive. So it's something that needs to be tackled. But what we found was it's definitely about personal relationships. So there's a reliance on personal rather than professional institutional relationships. So that means that sometimes in countries you'd have gatekeepers to the data that you would have to negotiate your way through. There's the fear of data stealing, which is warranted, I think, in some cases. But there's also a lack of clarity as to what can be shared. And I was thinking about this recently. We're in an era of talking about open data, and yet also an era where the GDPR has recently come in and there are privacy concerns. So they're two slightly contradictory things. And when you talk to a researcher and say, can I have your prevalence data? One of the questions in their mind, apart from, oh my gosh, I have to clean it now, is, yeah, that struck a chord, is, can I share it? Have I got the ethical consent to share this data? And if I'm in a consortium with other groups, do they all agree that I can share this data or not? So it's quite tricky. And I think with that in mind, I brought this up at MERG recently in Tanzania. I think it's something that we do have to think about quite seriously, because I think it might come back to bite us if we don't start thinking about it now for malaria control programs, and also, I guess, more broadly. So timeliness was a massive issue for us. There's a very short time between when the data becomes available for us to synthesize and when it's needed for a strategic plan or a malaria program review or an MTR, a malaria midterm review. And sometimes that window isn't available at all. So in some cases, what we end up with, because the data would only become available 2 years after it's been collected, are prevalence maps that are 2 years after the fact, really, being used for planning. And that's not ideal. And it's very difficult then to convince people that this is something that they should use. That then relates to the relevance of prevalence for operational planning, because if we've got prevalence maps that are 2 years out of date, then people begin to question, well, can we use them now? And then they begin to rely on the routine data in full awareness that that data quality perhaps isn't the best. And so this kind of brings me to this last point of routine prioritization of data use is low until it's really high. So in a program, we would often get emails saying, we need a map now because we've got a concept note going in. And if you've got 30 countries developing concept notes at the same time, it doesn't become possible to then generate all of those maps, collate all of that data to provide all of that at the same time. And so really what I feel should be happening is, and I refer to a mosquito larvae, Joe Lyons, I hope you're proud of me, but in a mosquito larvae where it's constantly collecting food in, I feel like that's what national malaria control programs should be doing, where the food is data. Constantly feeding data into that program and collating it so that it's not urgently needed and there's an urgent search for information and data to feed into national strategies and malaria program reviews. And then you might even out those peaks of need. And the last challenge, and the biggest one, and this is why we've kind of focused on it here today, is how and when to target. So I think often we would find ourselves perhaps in a bit of an uncomfortable situation where we present a risk map to countries and the overall goal is to try and target interventions, but actually we don't have guidance on how to guide countries in doing that. And this is something I think WHO recognise, I know the Global Fund recognise, But it's kind of becoming quite crucial, especially as we begin to talk about granularity and more targeting and more effective use of resources. So I think with the operational targeting, that maybe month-to-month or year-to-year planning is perhaps easier, where to concentrate your supervision, where to focus or shift your focus of the BedNet intervention because your coverage is low. But the other bigger, more strategic questions about where to spray, where and when to use new technologies, what coverage is good enough, what your indicator targets, how good are they, and when to stop, and what do you do if you stop and something else happens? Do you go back in with that intervention? Is there a fallback plan, as one of my colleagues said yesterday from Uganda? And I think that was a bigger challenge for us, or one of the biggest challenges for us in working on this. So I'll stop there, and I will just say a massive thank you to all of you. And I just want to highlight that I stand here in front of you, but actually it was a massive team who worked on this with us. And so it's on behalf of them that I'm presenting this to you today. I look forward to the rest of the discussions. Thank you.
So thanks, Caroline. You've done well with time. We've got a couple of minutes if there are any particular questions that anybody would like to raise, some clarifications. Is everything crystal clear so far? Quite an involved programme, very upfront with the challenges, which I certainly recognise. I hope. Okay, Joe.
HMIS2. What is that going to be?
DHIS2.
Yeah.
I think.
Do you want to come here so
yes.
people can see?
So I think it was Tedros who said it has created a bit of a mini revolution, DHIS2, that with internet access. So I think certainly the data is becoming more available and more immediately available, but that doesn't mean the quality is there yet, because you've still got that weak link between the peripheral and the district where it's inputted. So it's making a big difference in terms of now we can perhaps see where the quality is not so good, and you can concentrate on that. But it's also, it got its own challenges. It's not a silver bullet. And the other thing with the DHIS2 is that it's routine data, and prevalence data offers you a different set of indicators and a different set of measures. So they're complementary, as opposed to one kind of replacing the other. And I think that's something that we have to bear in mind, that we need the two to measure things going forward.
You talked about some of the challenges of collating data and the data that's available. And I wondered whether you had a comment on the types of data that are available, given those challenges, and whether, is there funding available to address the kind of data that you really want? I'm thinking there it's partly related to the data sharing. It's relatively easy to share the data, but sometimes the data is just not there in the first place.
Yeah, that's true. So in some places, yeah, there's no data there. There's no data, geographically there's no data in certain parts of countries. So you're constrained by that. In some countries, it's been quite phenomenal. I know in Kenya and Tanzania, for example, where they identified gaps, geographical gaps in data, they got funding to go in and then do prevalence surveys to fill in those gaps. So I imagine the funding for data depends on what's going on in the country, I think, and identifying where the data is missing from, geographically, say. In terms of the types of data available, what we required were, and Imelda can talk to this a bit more, was geolocated village-level data. And positive, negative, RDT or microscopy positive, negative. Again, that's not always available. You don't always have the coordinates, or you don't always have the information down to that level. So that, I mean, I think the team in Nairobi often would spend a lot of time trying to fill that back in for us. If we had a village name but not the coordinates, they spend a lot of time trying to validate where that information was coming from. So it's also quite a time-consuming task. I'm not sure if I've answered all of your questions. I think there was a third one that I missed.
So it was more like funding. Should we be actually trying to gather more data?
So I'm not going to preempt. I think both Jane and Justin's presentations will be talking a bit more about the data that we want and the data that we need. But I think it depends on the country context. I think it depends on how much data is missing and where the country is in terms of their overall transmission intensity as well. Which is a bit of a circular reference because you need that to be able to know the transmission intensity. But yeah, I think it depends on the context as to whether we should be putting more money into that or not.
Last question for now.
One thing I didn't get from a really clear presentation is just about how hard it is to collect data, actually. And what I find in the programs that I help to run is a real request to collect less rather than more, and ways in which it might be easier to collect that data. So, and I don't know anything about this project yet, and I'm excited to hear, but did you look at being more parsimonious with the data that was being collected? And also, were there ways of easing data collection? So rather than really quite complicated methods to get even routine programs.
Did we think about being more parsimonious? I guess the underlying rationale behind what we were trying to do was to make use of the data that was available. So for the risk mapping and the intervention, in order to synthesize it into the kind of more accessible evidence for national malaria control programs.
But not a minimum set, for instance?
No, we didn't define a minimum set per se, although we did have a set of criteria that we needed to have for the maps to be able to be done. And that was quite minimal in some ways. It was plus or minus, RDT positive or negative, geo coordinates, and say a village name, and numbers of people, and age, yeah.
Right. I am going to thank you now, Caroline.
Okay.
But maybe this is something that we'll come back to, sort of the minimum essential data that's required to inform decision making at a country level. I think that would be a good topic to dwell on a little bit, and in particular to hear from the Malaria Control Programme representatives who are in the room to understand what the challenges are as far as they're concerned. But now I'm very happy to welcome Imelda Okiro to talk to us a little bit more about the technical side of the approach and the way this field is moving. Imelda.
Okay, it's just different when it's popped up behind you. Let me.
Is that your one?
Yeah.
Yep. Is that you? Yeah.
Yes.
Yeah, perfect.
All right. Again, just to remind you that I'm from the Kemri Wellcome Trust program in Nairobi, and my presentation will focus on the mapping process that we used within the LINK project, but also looking ahead to how could this evolve going forward. So I think, not to belabor the point, but I think we all agree that a one-size-fits-all strategy is not optimal, and there's a lot of waste of resources and time, and that understanding the heterogeneity of transmission and taking a more targeted subnational approach to optimizing your intervention is useful going forward. So David spoke about this. So the last malaria report indicated that after unmatched progress in malaria control, there are several countries that now are seeing a reversal in the gains that have been made. So 24 countries had more cases in 2016 than the previous year. So that is quite a worrying situation at the moment. Along with this is that funding has stagnated over the last couple of years, and even the amount of funding that's available is grossly insufficient. So how are we dealing with the current situation to get the most value for the money that's available for controlling malaria? So along this background, over time there's been a huge increase in health data that comes with geospatial coordinates, and that has provided the foundation for developing the methods around model-based geostatistics. So why do you need to map? If you have adequate data, then the value of model-based geostatistics ceases to exist. So if you do your surveys on their power to provide estimates at subnational level, then you don't need to apply the models to make predictions at subnational level. The reason we do this here is that in most countries we have inadequate data, hence the reason we apply these models to provide estimates at locations that are useful for national malaria control programs. So how do we do this process? So there's a basic rule of geography that says that things that are close together are more similar than things that are far apart. So that is the basic principle or foundation that underlays the science of model-based geostatistics. So essentially what you're trying to do is make a prediction to points where you have no information using the information from villages or clusters around that. And that's the process of interpolation. So you borrow information in space and make predictions to whatever year you are interested in. The other thing that we also do is an age correction. So typically surveys are done at a population level, but they survey different individuals of different ages. So how do you standardize across all of those surveys to make the parasite prevalence estimate comparable across surveys? So we do a process of age correction, and within the model, we also adjust for errors within the data. So again, to say that we don't just assume that there's a relationship, there's a process of testing to identify where, within what range does this relationship hold. So at what point do values from different clusters stop being correlated? Using that information, you use that within your modeling framework to apply it to provide the continuous surface. So what Link was trying to do is provide this information at meaningful spatial resolution for the national malaria control programs. And this varies across countries, but it's typically a district or a county or a state within the country. So this is an example of data from Uganda that you've seen before. But the value of this is that it's at the health district, so adds value to the way the programs are thinking about, okay, what is the malaria situation within our country at subnational levels? But also importantly, it's looking at more than one time point. So it's insufficient to just know where you are now. It's important to know where you've been historically to identify those places that for whatever reason may not be doing as well as others. So in this series of maps, the map on the left side shows that there are certain areas that, in fact, you're seeing an increase in parasite prevalence. So if you're on a national malaria control program, you're probably thinking about what is it about these areas that explains what we are seeing. So there's value in looking at change over time. So we didn't stop there. We've developed a metric that we are calling an exceedance probability, which is a measure of certainty around the estimates of parasite prevalence that we are developing. So what is this exactly? Based on a country-relevant threshold, we are able to tell you with a level of certainty whether that particular area is below or above that threshold. So for example, this is an example using the Kenya information. So how certain are we that the places that we're predicting to have a prevalence of less than 1% are really less than 1%? And if you're thinking about changing strategies or maybe stopping to give nets and doing something else, for you as a program manager, you probably want some measure of confidence around that decision. So this is what this is doing. So it's exceedance or non-exceedance probability, and it's a measure of how certain we are that prevalence is above a certain threshold or below a certain threshold. And these are examples of possibilities where if in places like Western Kenya, where you see that prevalence has remained high despite substantial investment in controlling malaria, what would you do as a malaria program? So the options there would be considering maybe incorporating new interventions like the RTSS vaccine. And in places where the prevalence is less than 1, you could consider maybe stopping giving people ITNs and thinking more about improving your surveillance and focusing on better targeting and increasing the coverage of prompt treatment in that area. So this gives you a sense of how programs could use this information to make those decisions. So this is a map that shows results from Kenya, and the map on my extreme right is showing prevalence estimates over 3 years from 2013 to 2014. And the yellow section shows areas that have been predicted to be less than 1 over the last 3 years. The dark red and maroon shows areas along Lake Victoria that are predicted to have consistently had estimates greater than 30% in the same 3-year period. So along with that map of the results, this is the map showing you the exceedance probabilities. So any area that is green or light green shows you that in these areas, we are greater than 80% sure that these areas have had a prevalence estimate of less than 1% for the last 3 years. So this information is useful for the malaria control programs as they're thinking about maybe changing their approach in these areas. And the same is true for areas along Western Kenya. For those areas, we are more than 80% sure that those areas have remained above 30% in the last 3 years. This is another example showing you the same information from Mali, but you'll note that these are different thresholds. So again, I impress upon you that the thresholds are country-specific and unique to the country context. So in Mali, for example, there are no areas that are predicted to have a prevalence of less than 1%. So that information is of no use to them. But you see that comparing the 2012 and 2015 map, you see that the areas that are predicted to have a prevalence of greater than 50% are reducing, so it's shrinking. And there's only one area that is in Bamako that is predicted to have a prevalence of less than 10%. So the decisions around Mali compared to Kenya would be very different using this information. So the thing that we realized within the LINK project is that typically we would do a map, and in the next few months, the country would say we have new data and we need another map. Or that we are doing a global fund application and 10 countries want maps at the same time. So the burden of producing maps can be extremely variable and intense and unmanageable within the current structure of the project. So what we did was develop a web-based application that allows countries to create their own maps. So this is a snapshot of what the web portal looks like. So all they need to do is input a spreadsheet of all the data variables that are required to produce the maps, enter the thresholds that are unique to their countries, and fill in a few pieces of information, and they're able to produce their own maps. And the two maps are on the left are maps that were produced by participants who attended the training, and it demonstrates that this is something that they would be able to do from their desktops very easily without too much hassle. This is based on a simplified version of the modeling process that we use typically to produce the profiles. So in terms of capacity building within the ministries, this is a useful output of the LINK project. So we've spoken a lot about the challenges of using parasite prevalence to produce the maps. So in some instances, there's not enough data to make useful inferences from the raw data that we have. So for example, this is Mali, where in certain areas we were not able to make predictions because we just did not have enough information. The other challenge is that as countries move to lower risk levels, the value of community parasite prevalence becomes more and more reliable. So the use of parasite prevalence as a metric for tracking progress becomes challenging. So somebody asked a question about routine data. So this is speaking to how you could use routine data to fill the gap in countries where there's insufficient parasite prevalence information or that are transitioning to very low levels. So this is the using test positivity rate, and the map of Africa is showing countries that have either rolled out DHIS2 system or platform completely, that's the dark green, or the lighter green are countries that are in the pilot stage of rolling out the DHIS2 system. So it gives you a sense of the potential value of routine data to fill in this space. There are certain challenges with routine data. One, in many countries, it's grossly incomplete. So many facilities don't report, and those that report sometimes don't report consistently. The other challenge is that it's mostly covering public health facilities, so you're excluding many of the private facilities. The other challenge is utilization. If you don't show up in the clinic, we have no information about what's happening to you. So those are things that you have to be aware of as you're developing the methodology around using routine data to produce valid estimates. So this is work that we're starting to think about in terms of developing the science around using routine data to provide similar estimates. I was also asked to speak a little bit about receptivity, and really this is something that has come up as a function of countries that are thinking about elimination and are thinking about the risk of reintroduction as a function of human population movement. But in countries that are in low stable endemic control, it's also a potential problem if you're thinking about maybe scaling back in terms of your interventions. What's the potential risk of rebound if you are to stop giving people nets? So typically what you would need to address this question is countries that are naive, that have not had any level of control, but there are very few countries in Africa that you would say have had no level of any intervention over the last 100 years. So in lieu of having that, what you could do is look at a historical maps to times before the reinvigoration of the new control effort. So this is looking at a series of maps from Kenya, and this is work that was published. It just came out today, and the primary author is Peter Masharia, who's in the audience. But it shows the change in Kenya since 1990 to 2015, and it gives you a sense of the potential rebound, the rebound potential were you to stop your current levels of control. So the early series of maps, the first row, gives you a sense of how much change has happened over the period and what the potential rebound risk is. It's important to know that there are instances like in Uganda and Kenya where they stopped IRS programs, and that has also demonstrated the fact that if you stop interventions and don't replace it by something else, then all the gains that have been made are lost. So by way of summary, I've shown you a glimpse of how we've applied model-based geostatistics within the LINK project, highlighting the fact that it's important to translate the science and promote data ownership and capacity within the national malaria programs, because projects end, but the needs continue beyond projects. So leaving the capacity within programs to continue this going forward is useful, but also understanding the limitations of parasite prevalence data and thinking forward around the utility of routine information and how that could become a useful data point going forward. Thank you.
So I'm hoping you're not going to run away. I personally could actually ask a long series of questions because this is fascinating. It's technically challenging, but hopefully we've all at least got some insights. So are there any burning questions for Imelda right now? Yes, Kate.
Thank you so much. Incredibly interesting. And I'm really glad you brought up this issue of malaria-genic potential at the end. So I would like to ask a little bit about that. When Carrie talks about the sessions that you carry out with country programs to present the data, the maps that you've developed, and prompt discussion around that and what it might mean for decisions, what guidance do you give around that malaria-genic potential issue? Do you present older maps and newer maps and talk through the issue of malaria-genic potential, some of the serious issues that have been faced in countries like Uganda, for example, or is that something that they're left to deal with by themselves, basically? I know Carrie also talked about this issue of the gap between where is the guidance or the guidance on what we should do with the data once we have it, but is that part of that? How do you deal with that very big problem?
Okay, there's two bits to your question. The guidance typically should be provided by WHO. There should be clear guidance on what countries should do if they're thinking about stratification within the low stable endemic, and that currently doesn't exist, but it's something that they're thinking about. The Kenya situation is a little unique. It's not typical, so LINC did not go back that far in time. So Kenya is slightly different. We're based in Kenya, and this is part of a PhD students' project, so that's slightly different. But in terms of discussions around shifting strategies for places that have been shown to, say, for example, be less than 1% over 3 years, those discussions are happening within the development of the new strategy. So helping countries think about what are some of the options that you could consider for those areas that you would be thinking of doing something different. But the guidance around what to do in those areas does not exist. So for even us in our discussions, it's an unknown. Yeah.
Thank you very much. I think in the interest of time, we're probably going to have to move on, but this is an absolutely critical component. And I think one of the points which LINC has helped to illustrate the need for guidance are for countries about rational approaches to prioritising their allocation of scarce resources. So maybe we can come back to this in the panel discussion. We're getting several issues thrown up into the air, and we'll continue doing so as we welcome Jane Webster to come along and talk to us about the challenges of using evidence to target interventions, the results of the evaluation of LINC that Jane's been coordinating. Thanks.
Very much. Good afternoon, everyone. Just one slight clarification on the title and what David said there is what I'm not presenting is the evaluation of LINC. What I'm presenting is the challenges, what's happening in terms of targeting within countries. So it's an element of the evaluation. It's not the evaluation of LINC. So the title is Challenges to Using Evidence for Malaria Intervention, Strategic Decision Making, Rationalising Resources and Interventions. So does that look wobbly? No? From here it's very, anyway, it's okay. So in terms of background, again, I'm not going to say an awful lot here because a lot of what I have on this slide is what David said. So, but basically the context is we do have changing, I even have a lot of the same statistics, David, from the same document, I think. So we have a situation of changing malaria epidemiology, decreasing transmission in many countries, declining external resources or insufficient external resources to fuel what we hope to achieve from the GTS. We have increasing insecticide resistance, so greater need basically for rationalising resources. And our take on targeting is if we're rationalising resources, we also need to think about rationalising interventions. So we have to think about the global goals. Countries really do value global goals and they abide by them. But there are also national realities to how to interpret global goals within the context of the countries. And the decision making on policies and strategies is often built around local realities, national realities. So in terms of the LINC evaluation, we did many things within the LINC evaluation. We've done quite a lot of synthesis of publicly available data. Here, I'm just presenting the stakeholder interviews that we did. So we did stakeholder interviews, as you can see here, in 6 countries. 1, 2, 3, 4, 5, 6. In terms of what we were looking at with stakeholder interviews, we were interested in the LINC maps and processes. So how were the maps used? For what processes were they used? We were interested in looking at what were the data sources within countries and the availability and the quality of that data that were used to make decisions. We looked at data use and pathways, including prioritization and targeting, which will be the focus of this presentation. And we also looked at the political economy of decision making, which Justin will be presenting on. So in total, we have an awful lot of data. We conducted 177 in-depth interviews across these countries, and anyone who has used qualitative data will kind of think, wow, that is a lot of data, and it really is a lot of data. So that's why I'm saying we are not presenting the evaluation of link here in 20 minutes. So we also had some global level interviews. Everything was digitally recorded, verbatim transcription, translation as required, coding and analysis with in vivo, standard qualitative techniques we used. All of this required ethics approvals in these 7 countries, and I'd just like to give a big acknowledgement to the work of Ludovica Gilardi in this. Incredible to achieve that in such a short time. We also conducted policy document review. So in terms of what I'm calling rationalizing resources and interventions, or prioritization and targeting, we don't really have a good definition of those. This is why, Carrie presented her definition. The definition is quite a moving target. The definitions that we used within our evaluation and our questioning of stakeholders within countries was that prioritization is the choice of an intervention or a type of intervention or a type of delivery method over another one. So prioritizing an intervention or a delivery method. Targeting was geographical or population-based, so we used selection of specific geographic areas or population subgroups for delivery of an intervention. So those were the definitions that we used. In terms of is this happening, there's been quite a lot of contention over the years about prioritization and targeting, about the words used for it within a context of universal coverage. Stakeholders, basically this is happening because of the challenges with funding. So whilst recognising global goals, there are challenges with funding, and decision makers at the country level have to make decisions on how to use their limited resources. So they need to prioritise interventions and they need to target interventions. To do this, they need data. So there was a call across all of the countries, we need data, we need better data, because we need to prioritise and target. So in terms of what is being used at the country level, and just to reiterate again, what I'm presenting here is the viewpoint of decision makers and stakeholders in country. It's not that I've decided this is what it is the viewpoints of decision makers. So in terms of epidemiological risk maps, we looked in depth in 3 countries about the decisions that were being made on which maps to use. So we have examples of 3 different kinds of maps here that are used in these 3 countries. So we have an example of the Plasmodium falciparum parasite rate map that Imelda has just told us about. This is a map from Kenya. It's sub-county level, so a model map. The middle one is an incidence map. It's data based from the HMIS in Malawi, and it's based on annual parasite rate. You'll see there are some differences in the resolution and in what can be gained from these maps. The map on your right-hand side is from Democratic Republic of Congo, and this is based on the Demographic and Health Survey prevalence data. So we have 2 maps here using prevalence data. One is modelled, one is basically just from the DHS. So 2 different kinds of prevalence map, 1 incidence map. In terms of the choices that countries are making, Sometimes it's based on what they want for the general use of the map. They're using them for epidemiological stratification, looking at seasonal malaria transmission areas, malaria epidemic-prone zones. Sometimes it's about showing variation across districts and showing decline in incidence. So a great need from all countries to show their achievements. And so incidence is a good indicator for that. In some countries, it's about our moving towards elimination. So we're looking at what are our pre-elimination areas and what are the consolidated control intensification areas. So that was a particular case with DRC. In terms of targeting, this varies across countries. So, for example, Kenya is a very different situation from most of the countries. So Kenya has sub-county modelled maps, and this was something that was very much celebrated by the stakeholders in Kenya. They were very pleased with what they could do with the maps. But Kenya is also decentralised, so that the decision-making follows with the use of the maps. And they were using those maps to look at epidemic-prone areas, targeting of IRS and IPTP within epidemic-prone areas, because in Kenya, IPTP, for example, is not given across the country. It's only in endemic areas. But they needed to understand the epidemic areas and where the IPTP and IRS may need to be deployed. IRS was the main intervention that was targeted across the countries that we looked at. Some countries were using targeting to identify particular areas where they would use different delivery mechanisms. So, for example, LLINs, distribution through schools in DRC. But overall, mostly the targeting was IRS, apart from in Kenya. So a quick thank you to Nicholas Della Santa and Tessa Lenneman for a very extensive document review that they conducted looking at how maps are being used in national malaria strategic documents. So they've looked at 165 documents across 46 countries and got some very comprehensive coding down this side that I'm not going to go into. But basically what this graph shows that is the yellow lines, these yellow lines here, are incidence and prevalence data. So even though countries are using some countries are using incidence, some countries are using prevalence for their preference, you can see from here that incidence and prevalence data and other data are not really being used very much for defining strategies and policies, or for identifying prospective intervention target areas. They're much more used within these documents for context, just looking at context. So there's a real gap in use, the potential use of both maps and data. Look, this is maps, using maps for in national strategy documents. In terms of wider data, moving on from maps, I decided to take quite a British focus on this. So within Britain, and I think maybe other countries as well, we have quite a pessimistic view on things sometimes. We have things called Sod's Law, we have things called Murphy's Law, where we assume that the worst is happening, and that means then that anything above that is good. So I've used here, this is something I got from someone that many of you know, Professor Don de Savigny. He uses this a lot, and it's always impressed on me very much over the years. So Mr. Finagle, many years ago, decided that in terms of information, the information that you have is not what you want. The information that you need, that you want is not what you need, and the information you need is not what you can obtain. He did have an extra one on cost, that the information that you can obtain is too expensive, but I decided to leave that one out. So we're beginning from a very pessimistic view. But my question was, is this true? Is it true that the information that countries have is not what they want? Is it true that the information that countries want is not what they need? And is it true that the information that countries need is not what they can get? This was the question. So, in terms of the data that countries have, and this addresses to some extent Sean's question to Caroline, is mainly the type of data that is used for the maps too. So we have the demographic and health surveys, population surveys, the malaria indicator surveys, the mixed surveys, we have modelled data and routine HMIS. I won't go too much into surveillance because that has a different focus, I think. So we have different metrics, we have different population groups collected across these different methods. We have different timing. Of course, the demographic and health surveys are only every 3 to 5 years. So if you're in DRC and using prevalence, then you only have that data available every 3 to 5 years. In terms of what countries want, based on these different kinds of methods, was the countries that were using the demographic and health surveys, the population-based surveys, they want district-level representative data. So demographic and health surveys are representative at the national level, they're representative at the provincial level. They don't go to the district level. They wanted timely, more frequent surveys, obviously. In terms of the modelled data, there was an expression from some countries in that they didn't trust it. This coupled with understanding, so understanding exactly what went into the model, what made the model work, where that data was from, that lack of understanding could create mistrust in some countries. Routine HMIS, we've heard a lot of challenges. We all know the challenges to routine data. The challenges of representative, Imelda's already mentioned the private sector and the community not feeding into that data, so the data not being complete. Some countries were saying our data is complete. I think we have some reservations around that, the real completeness. But there is a different perception across different countries about the completeness of the data. There isn't a difference in perceptions across countries about the validity and the accuracy of that data. That is a common worry. Aggregated data, countries wanted, who are using HMIS data, wanted digitising. They don't want aggregated data, they want digitising at the health facility level. I think we all feel that would be a wonderful thing, but not so easy to achieve. So those were the main ways, the main wants from the data. So basically, we have three major forms of data available to countries, 2 based on prevalence and 1 based on incidence. Subnational data is what countries want. They want timely data. Caroline already mentioned it. Timely is not just available all the time, it's available at the right time, fitting with when the major documents are needed. But what I really want to emphasize here is the call is not just about the technical description of the data. It was very, very much the responses from countries were on data that we can trust, data that we own, and data that we understand. All of those things linked together, but these were by far the most, the biggest call. So in terms of, again, what we want, general desire for subnational data, but awareness of the lack of quality of the data. Timely data to align with the malaria programme reviews and with the national malaria strategies, also with the Global Fund concept notes. Desire to own, desire to use routine data. Big desire across countries for that, but understanding of the limitations. I think the major call was for was continuous engagement. So including participation in not just in the final products, but in the choice of the type of data that goes into maps and goes into prospective decision making. They want to be included in both the model and the type of maps. And that was, according to decision makers, necessary for adoption and use of maps. And I think any of you who have been becoming more involved in recent developments in evaluation methods will know about how evaluation has moved just from impact to really understanding what makes something work, what are the mechanisms that trigger the use of things. And for me, hearing this, asking for ownership, asking for understanding and trust are primary mechanisms for a decision maker to use something to make a decision with. The data we want is not what we need. So the call, I think, again, it's been mentioned, lots of countries saying they want subnational data. A lot of those countries have homogeneous, relatively homogeneous transmission. So the question, and we posed this question again in the workshop with stakeholders, with National Malaria Control Programme representatives yesterday, would it make a difference if you had district level data, if you have homogeneous transmission across the country? And no, probably it wouldn't for strategic decision making, but it might do for planning. So I think there's a mix between what is needed for strategic decision making and what is needed for planning. So that needs teasing out, I think. So what we want is not what we need. Overall, I would say that isn't true. Stakeholders, decision makers know what they need, but maybe with the subnational data, is the time now or is it later? I would question, I was talking with Joe this morning about increasing insecticide resistance. Maybe there's a growing need for more subnational vision of insecticide resistance. So maybe that is slightly different. The data we need is not what we can obtain. So the big calls for high quality data, none of this will surprise you, but it is what is coming from the countries. High quality data, resolution appropriate for use. So what is the context of the country at the moment? So what is the resolution of the data that they need? Timely data, not just available all the time, but not just the frequency, but also the strategic points. But overall, the major message is data we trust, data we own, and data we understand. So of course, data we own, the HMIS is data that countries own. It is their own data. Data we understand, countries understand HMIS data. Data we trust, no. There's more work to do on that. So back to Mr. Finagle. The information you have is not what you want. I think that is true for the countries. That his statement there does hold. The information is not what you need, true to a large extent, but there are some reservations on that. The information you need is not what you can obtain. Right now, exactly what everyone needs, not quite there, but it has to be there. If we're going to achieve what we need to achieve, we have to put on a spurt and make sure that information is there. So in conclusion, targeting is used. It is used in many countries, but mainly for IRS at the moment. Apart from countries where there's quite a lot of heterogeneity, such as Kenya. The decisions are based on resource availability and rationalisation and heterogeneity of malaria transmission. This is back to Kenya. IRS, the main intervention to be targeted. Use of maps for defining policies and strategies, not targeting, is limited. Or for targeting. So that the use of the maps was mainly contextual. So at this point in time, I would say at this point in time means the latest malaria strategic documents. Stakeholders are aware of the limitations of data and the data available. Decision makers want data that they own, understand and trust. A need for guidance. Everybody has mentioned that it's something that has been mentioned for many years. There is a need for guidance. How to focus at the country level, to bring together partners to help with guidance, or in the lack of guidance to come together and discuss. Maybe that's the technical working groups. All of the countries, or most of the countries, have technical working groups where a lot of the decisions, the real decisions, are actually made and then signed off by ministries. Need for targeting based on heterogeneity of transmission. So the targeting is about heterogeneity, but heterogeneity is increasing. So David mentioned that transmission has fallen in overall by about 20%. That fall in transmission is not uniform across countries. It's heterogeneous, so heterogeneity is increasing.
So I'm doing a terrible job of keeping speakers to time, but there's so much interest. There are only specific quick questions for Jane right now. We've actually run through the time that we had available for a break, but I'm sure we should take a few minutes. We thank you, Jane. Let's take a few minutes, 5 minutes or so, to stretch our legs, invigorate our lungs, reflect a little bit on what we've heard so far, which has really come from people directly involved in the LINK programme, before moving on to hear some other perspectives on some of the realities that have been faced. So back in 10 minutes, please.
Yeah.
I made a folder for the...
Yeah, that's great. And I'm just, I just have an updated version.
Right.
That should be fine. Yeah, thank you.
You want to just test it, you can if you want.
It should be fine. Anyway.
What are you trying to do?
What are you trying to do, Tom? Don't touch anything.
do what we like here. Now we can do it, because that's holding.
Yeah, only thing is, I've got to open that up every time I want to go on it.
Yeah, so that's, you don't worry about
Is
it.
it not worth making a background?
I'm coming out, no.
Okay.
I'm coming out of it, and all they're seeing is this.
Yeah.
And so you just do it, no matter what the room sees. You're crash changing, basically.
Alright.
Because you can't have a holding, you can't cut away to the holding slide.
You can't just have that as a background?
You can,
on that screen, on the extended desktop?
You
then
can,
every time
but
I
it's,
come
the
off
quality's too low.
Oh,
So it comes through on the video, very low quality, and
Right.
in the room, so... So don't worry too much about what people see in the room.
Alright.
I will come out of the composited thing, and so I'll see them asking questions. And when they introduce someone else, just load it up. People will see it.
Alright,
What they'll see is
just me.
No, they'll see.
But they only see that background.
What they'll see. That's what we got there at the moment. So you can come out. You can come out there. Got too many slideshows going.
Yeah, they can all...
They'll see that.
They'll just see that.
That's fine.
Yeah. Alright. Cool.
You'll see in the main room tonight.
Yeah.
Got a lot more new and fresh on the room.
Yeah, alright. Cheers, man.
It's taken me like a year or maybe 20 to
Right. Well, welcome back, everybody. When I saw the refreshments on offer, of course we couldn't curtail the break as much as perhaps we should have. But welcome back. Thanks for making it back reasonably promptly. And we continue now with a few more presentations before a more open discussion. As I say, getting perspectives from different corners, different angles. So I now welcome Damien Ruchazana to talk to us about the processes around decision-making for malaria control in the Ugandan malaria control programme.
Thank you so much. I'll drill on the Ugandan experience and how we understood the whole topic of process of decision-making. But there are a number of countries here that might have different experiences and contexts. And I think we are chosen because we are at that point, we are a bit amateurs. We are at the point of the decision-making for the stratification and rationalization. Other countries have a bit moved ahead, but we are at that point of developing our strategy and what decisions to take. I'm doing this presentation on behalf of the National Malaria Control Program Manager. I wasn't able to be here because we are hosting the UK members of parliament in the country with the president of the country, and they're looking at a number of malaria interventions. And so that was yesterday, so there was no way we could make it, and also together with Daniel. Well, there are quite a number of decision makers when it comes to malaria, but I shall mainly drill on the malaria control program, understanding our context as a country, that the fact is that there's a lot of out-of-pocket expenditure. So the community is a big decision maker on malaria. There's a lot of the funding, most of the funding, over 80% is donor funded of the malaria intervention. But we are going to dwell mainly on the decision making at the National Malaria Control Program. Within that perspective, that most of the decision making might be outside. A number of decisions might be outside the National Malaria Control Program, and also putting into the fact that there are many determinants of this decision making. I kind of put the decision because when you look at that, when you look at the decision, you're hoping that the decision is evidence-based, the decision is structured, it has a good process, but there's a lot that happens. Is it first evidence? We look at the WHO recommendations. We have to consider donor preferences. The ease of implementation, stroke how feasible is it for us to implement whichever decision we take, the cost effectiveness and acceptability. Because of the ease of implementation, how acceptable is this to our stakeholders, and which populations are vulnerable, and the donor sustainability beyond if it go into the decisions, and we mentioned that the prevailing environment, political situation, security, those play big roles in how we make the decisions that we take. And again, that's the burden of the disease. That's where beyond malaria, where they are competing, we have to again compete with other diseases for particular resource envelopes. But as the desire is to have the evidence, but we exist in a number of the decisions, and the decisions around what we have as the building blocks is the financing decisions. How much money do you allocate? How much workforce do you allocate? Which products, which services are you going to allocate to a particular population? And where will you put the research? And what research will you do for a particular area? And also the particular service points we talked about in malaria, like if you're going to give that ICCM package, integrated community case management, to a certain population, or are you going to do test and treat, or are you going to give mass drug administration for a particular population? These are the decisions you have to drill on. And I'll just transition mainly to the pathway. Usually we look at the evidence. We have the consultation with WHO team, the Ugandan team, and then with our donors, and then we have the technical working groups within the program. And then beyond the program, we have what we call the National Disease Control. That is when you're looking at each is to make we say this is the decision you have made. We want to take LINs to this area. We want to take ICM to this area, and we have it in our policy or strategy. This is how these are the teams we all have to involve, from the World Health Organization to the in-country partners up to the top management of the Ministry of Health. Now, at the National Disease Control, which is chaired by a commissioner, then at the senior management, where it's the permanent secretary, then the Minister of Health at the Health Policy and Advisory Committee. Now, that is very critical that as we think of the decision, that all these are convinced of the stratification of the decision to take the intervention. Again, as we're saying, we are looking at stratification as not only saying this area is low incidence, this area is high incidence, moderate, but which interventions you're going to have in those areas. Now, when you go to the point of the interventions that you're going to have in those areas, then you have to, this is a path that you have to convince all the way to the minister, but from the stakeholders as a country. And we are we're now developing our strategy that will begin in 2020, and these are the processes we have to be thinking about, that we have already started thinking about. Of course, we hinted on some of the issues of timeliness, like when do we need these maps, okay, to make these decisions. Okay. We have been having routinely maps that we have been using weekly, monthly to make a number of decisions, but what about which decisions do we need to make for? But what information products shall we need to be making? Do we need, what about the prevalence maps that will show the picture that we have? Because as you mentioned, the gaps of the routine versus the information that is not coming in. How these decisions that we are making weekly, that we're making monthly based on routine information from the health facilities, are they the right decisions? Based that we're not getting, we're not using the prevalence maps that come also after a long period of time. And of course, the number of products you are currently using, but as again, I was saying that this is based on routine. So there are those, as it comes with the challenges of the routine information. And then again where are the best? We have had a number of meetings where we have shared this information, but is it the best way to share this information? When you send the minister a map, is it the best way to share the information? When you have them in a meeting, is it the best way? Do you have multiple meetings do you have meetings with them? Do you have it in a poster, in a blog? What will be the best way to have this shared? So we're still looking at how can we have the best way to share this information, and then the interventions, of course, have to align with the number of documents. They are national strategic documents, but also they are documents by the World Health Organizations that we have to align in. Much as I mentioned, we have a number of interests. We have, there's when you have a politician say, or a donor or a country come and say, no, why don't you do MDF for the whole country? Okay, so the number of strategic documents that you must have in place that you look at and you have to adjust. But also putting into fact that when you're like now when you're reviewing our policy that because 220 is close by, a number of these stakeholders will be coming in and saying, why don't you do this? Why don't you do this? Why don't you do this? So we have to be thinking about how is the best way to convince them, how is the best way to make them use the evidence that the minister who is having a meeting with the minister of another country suggesting maybe we do larviciding for Uganda, how will he use our information to say, no, I have this information, I'll not do the larviciding, or I'll do the larviciding. So those are some of the challenges and areas we are looking at. So, of course, the stratification has been well received, and there's so much desire for the maps. As this was one of the maps that we had done for 2016, and really it has been taken by most of, it has been highly requested by in-country partners, even a number of lower levels districts that would want to have the country picture. We have had this country map, so the desire is there, and of course you have begun using it a lot for the planning. But again, this is mainly epidemiological. So what about the entomological? Should we be providing both entomological and entomological to the stakeholders, or we just leave it to the entomological? And most of our action is at a district level. At a district level, we don't have that stratification. It's just one color or one picture. So the district would want, so does the district go into using their routine data that has its gaps at that level, because it doesn't have that, like how Kenya is lucky to have the sub-county information. But given at the district, there's a lot of my decision making, what happens at the district level. So there's that challenge at the lower level. To what extent can we could only go at a district level, but the desire by the districts, when they come to us, they say we want to have our own stratification, but we cannot go because of the limitation of the data, as Melda mentioned. I'd mentioned about the issue of how often the data comes in. Like in the recent struggle we had when you mentioned how quickly we want the data in. Yes, the demographic health survey was done for the country, but the data to be accessible, it took almost over 1 year, almost. So almost about 2 years. So if the data takes that long to be available, and then you have the analysis, how do we have a challenge with the stakeholders? Because when you show them a map of 2016, they say, no, we have had a mass campaign in 2017, so we don't agree with your data. So you have how will you convince them that let's go this way? So those are the challenges of and the resistance. Someone mentioned about also the resistance of the drug, the anti-malarials, but also the insecticide resistance. How do you bring them in also in this whole picture without making it so, without having a crazy picture for the decision maker? How do you bring all this in? The factors, and also there are serious variations within the populations. Most of our malaria is concentrated in the poverty, where there's high poverty area, the poverty where there's a lot of poverty. So how does it come in within the map? Because will it also guide your decision making? If you deny certain interventions, there are ramifications because of the vast differences within the populations. There's a lot of diversity within the country. This is more like a continuum. So one of what was came out clear is what are the cutoffs for this stratification. We've seen a number of countries with like Senegal, Kenya, Tanzania have had very nice cutoffs, but that's the challenge you're having. Our situation is a bit different because if you look at the Kenyan map, it's towards Uganda where you have the high what? The high prevalence. You look at the Tanzanian map, it's also towards Uganda. Then you have Congo, the challenges of the Democratic Republic of Congo. Then you have South Sudan up. So we are very receptive. So, but as we have a more like a heterogeneous picture, it's a bit of a challenge on which cutoffs particularly, and also the fact that WHO is moving a bit away from the cutoffs. It's like look at it as a continuum that you're implementing. As it improves, then you keep changing from pre-elimination to elimination, but don't think of a particular cutoff. So, because of that challenge of the cutoffs, the cutoffs, especially for what you want to implement, at this cutoff, do LIN. At this cutoff, don't do LIN. At this cutoff, it's not explicit. So it becomes a bit tricky to convince stakeholders. Again, as you may say, that the mindset of the program has to change. If we are to go into this, it's a bit much easier when we are in control. When you have not stratified, you say we are giving the whole country LINs, then we just, based on who has more cases, we give more drugs. Based on who has less cases, we give less medications. But when you look at looking at control versus elimination or pre-elimination mode implementation of malaria control is very complex. Rolling out teams, the cross-border surveillance. One of the areas that we have that is of low incidence is next to Rwanda and next to Congo. Then we have to have all those interventions in place. It will be very, very tricky and very intensive as a program to have this. Do we have are we looking at 2 programs? Okay, are we looking at, so one advocating for resources for pre-elimination, one pushing for, and then what is the balance in terms of who is providing the resources? Again, the other thing is that when we do the stratification, is that what we have been having is that the strata are not static, that this will be less than 1%. With an epidemic, with our high population movements, we have one of the most high population movements because of, as I mentioned, how we are situated. We are, again, very ethnically diverse, South Sudan, Congo, the Turkana pastoralists, and all that. So, and then we cannot say that this will be less than 1%. This will be so how do you keep changing? How do you keep changing the implementation based on how the strata are changing? As for some countries, of course, it's a bit easier. You have like a desert, but because of how the country is geographically and the population is, we cannot guarantee that the strata will not be changing. They have been changing. Then, as I mentioned, the role of the district versus the national program in the stratification. Do the districts also have what is their exact role in this stratification? They also need their maps, or we do present to them this national map, and then it's up to them to make a decision. These are a number of them still came out in our discussions yesterday. As I mentioned, we had this is just a little bit of from the Ugandan experiences. So, timeliness of the evidence is that there are times we want to make critical decisions, but we have to wait for the reviews. We have has enough evidence been generated to make a decision. Like when we are now in the process of reviewing our strategies and policies, there are a number of areas that do not have sufficient evidence. So you can't easily make the decision. And then, of course, it has come out a bit on that are we communicating to the decision makers, the teams from the research point of view and the M&E teams, and how best can you communicate to the decision makers, not just passing on to information, but information that will make them make decisions. There seems to be a gap. We are told give maps, do tables, do this, but so what? There's still a bit of a challenge on to what extent do I actively follow up? So have you made a decision based on my map? Which decision have you made or something? So it's a bit of a gap there. Then, of course, the cost effectiveness, the comparison of cost effectiveness data is really lacking in a number of these interventions. So for countries that are resource limited, the political side wants a lot of data on cost. What is the cost effectiveness comparison of the different interventions? We have a challenge there because you propose an intervention, but someone can just say it's not oh, airlines are more costly than whatever. So much as there's been data, there's been publications that can be argued against because they have not been vast enough on all the interventions, the MDA, larviciding altogether. What is more cost effective? Then also, I had mentioned the minimum in-country expenditure, then acceptability of the interventions. Because there's an assumption that once we do our stratification and we deploy, it will work out. We faced that in a number of quite very challenging. We had a mass campaign where I gave nets to the whole country, but the use has been really a challenge. The assumption was once you have it, you'll use it. Then also I've just wrote feasibility, but it's more complex than the feasibility. The country's capacity basically to implement a number of these interventions effectively. There are inherent challenges when we say that this place will give it maybe case management, ICCM. Does it have village health teams that are well trained that will do this intervention? Does it have a support structure? Are the politicians willing? It's beyond just saying you'll give them the intervention. Will they be able to effectively implement that intervention? And then also working on the demand for evidence by the decision makers beyond the competing needs. Then also the fact that still, of course, the bureaucracies do exist in our decision making. Of course, one of the things we're looking at, these are not that, these are suggested recommendations. Dealing with the room with a wealth of experts, and I'm just suggesting. So it's not cut in stone, okay? So, of course, a number of countries have, as we had yesterday, research agendas, but also to what extent are these research agendas of the countries implemented? So a lot of research is not on the research agendas and of the country itself. So you do research, give the country a product, and expect the country to use what previous Professor Webster had mentioned. Do you want this information? Then also a link needs a bit of support for the capacity to analyze and communicate data. Okay, but the assumption is that the program managers, the ministers, have this capacity to make decisions. What do we need to do in those areas? Okay, what do we need to do for countries to support this kind of decisions for, depending on the different stakeholders? What information products, what capacity do you have to do some capacity building? I don't know. It's a bit of challenge there. Of course, aligning this to the country processes. But you mentioned sometimes, as Imelda mentioned, sometimes you have 20 countries having doing their strategic process at once, which becomes tricky. But usually, if the research processes in the country try to align and be timely with this information for making those strategic decision-making processes, many times you have, as you have said, when is the map most useful? When is the information most useful? Is it useful 1 year, 2 years after we develop a strategy, when we can't change the strategy because we have 5-year strategies? So if the information you're doing is not coming out so quickly and it misses that period, it will be a challenge again to change. And then so more research on improving deployment. Because current, of course, much as we are talking about certification, a number of interventions currently are not deployed effectively. So you could stratify, thinking the intervention is not working well, but the intervention itself is not effectively deployed. So if you could deploy it effectively, then the intervention would achieve but the country might not know what's happening exactly. And imply that a country knows the challenges that it's facing, but to need support from the research arm to identify how to quickly tweak a few areas and improve on the deployment of that intervention. That was from the Ugandan experience. Thank you.
Oi, 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 he's running away very quickly, and I'm sure there are lots of questions here. But maybe, unless there are specific comments that anybody would like to make at this point, and I'm looking around for an indication of eagerness to engage or challenge, or are you, like me, in awe of the complexity of the realities that are faced by malaria control programmes? I was particularly struck by the long chain of events which starts at one end with evidence and then ends up way down the way with the ultimate decision making. So I think we're going to be coming back to many of these points, I hope we will, in the discussion. So for now, Damien, it looks like you've got off. And now let's welcome Kate Kolodziński from the Global Fund to give us their perspective.
Thank you.
I'm not sure it's theirs or hers.
It's theirs. Thank you. I just put my timer on here, see if I can win you some time. Okay, thank you. So from the Global Fund, we have got a bit of a multi-country view, basically. Because of the various countries we support in sub-Saharan Africa and elsewhere, it means we do get a bit of a cross-country view of the situation, the pressure that countries are under to prioritise, some of the challenges they face, and also some of the decisions they're taking. So I thought it would be a good idea to summarise some of that information. So I'm going to quickly go through these issues, talk about where the Global Fund fits into this process, look at the information we have about how much pressure the countries are under, the prioritisation decisions that countries have been taking, their challenges, and I want to look briefly at one specific example which we're facing right now, country by country, where programmes are going through the decision of whether they should be buying the new type of insecticide-treated net that recently has a WHO policy recommendation, pyrethroid PBO nets, and where that fits into their decision-making given the other pressure and gaps on the malaria budget. And just to reiterate what Damien says, my recommendations at the end, there will probably also just be suggestions for discussion. Okay, so the Global Fund is a financing institution. It is not a technical agency, so it's important to keep in mind the perspective that we come from. We go ahead with funding for malaria control programs that are in line with WHO policy. So we do have some in-house technical capacity, but the emphasis is on ensuring that the programs that we fund are in line with WHO guidance, rather than providing our own layer of technical guidance. So we have a technical review panel who are basically the technical group that review all the concept notes that the programs are putting together to determine that specific issue. Is this program in line with the national strategy and in line with WHO technical guidance? We do then have the in-house team who work to support countries if the WHO technical guidance needs interpretation for a specific context, because necessarily the WHO technical guidance is at a quite global level, and a lot of it needs interpretation to the different contexts in which countries are faced with decision-making. And also then decisions that go beyond where the WHO technical guidance lies. There is pragmatic decisions that we're seeing here from some of the countries that have to be taken that there is not WHO technical guidance for, and for a very good reason, because the evidence to underpin that technical guidance is not yet available. But just because the evidence is not yet there doesn't mean the decision goes away. So there's some pragmatic decision making that has to be taken, and we try to support with that. And also then, as the programme continues, to look at whether it's reprogramming, making sure it stays in line with technical guidance. In terms of the decisions around prioritisation, we try to promote the country decision-making process rather than bringing our own donor interest into certain interventions. And Damien talked about that, and it is something that we do see. The Global Fund tries not to do that, but others can talk about how successful that is or not. So country programmes make the prioritisation decisions when they're crafting their concept notes for presentation to the Global Fund for programming. We do try to support that decision-making process by making sure that they have all the best information available to them and to help with interpretation of that if necessary. We also have a modelling group that provides allocative efficiency models to countries if they ask for it. And those models are to try and look at what combination of interventions might be the most cost-effective approach for that country setting. But time and time again, we see that those kind of allocative efficiency models have major limitations. I'll come on to that later. Okay, so what pressure really is there to make prioritization decisions at the moment? And just before we go on, actually, just to touch on the issue of definitions that Carrie brought up. So when we're talking about prioritization, or when I'm talking about it now, it's really about how countries decide which interventions and which tools to prioritize. There then becomes a second step of, and would there then need to be some targeting of that geographically within the country? But really the hard decisions come at the first stage in terms of what we see happening anyhow, the decision about which interventions should I focus my investment in to get the best impact. So there is an important pressure at the moment to prioritize. What we're seeing is large funding gaps in the country budgets for even the main core interventions of universal coverage of public health facility case management or vector control. And as new interventions such as seasonal malaria chemoprophylaxis, for example, or more expensive tools such as now the pyrethroid PBO nets in the vector control space arrive, that pressure only increases, of course. And the main decisions that we see the countries facing are, what is the very top priority? Should I be funding case management commodities and implementation throughout all my public health facilities first? Or should I be funding universal coverage of vector control first? Because I might not even have enough money to do both of those things. So which of those is more important, ethically, in terms of equity, or in terms of impact on morbidity, or in terms of impact on mortality? Because what you're trying to achieve, your decision would be different. And where should I slot in the new high-impact interventions, which have got recommendations more recently? Where does seasonal malaria chemoprophylaxis fit in terms of my priority list? Where should I slot in new vector controls? Should I just focus on getting the basic tool for everybody, or should I look at upgrading, so to speak, some parts of my population? And then, critically, where does the monitoring evaluation fit in? When I don't have enough money to buy insecticide-treated nets for everybody in my country, how much of a priority should I put towards funding enhanced monitoring and evaluation activities? I need that data for my decision-making in the future. But how do I really justify the different needs for those monies? It's really hard decisions that are being taken. So this is just to show you to illustrate some of that pressure. So this was in the last, the Global Fund funds in 3-year funding cycles. So in the last funding cycle, this was the sub-Saharan African countries. The bottom 3 bars show the countries with gaps of more than $10 million in terms of implementing what they see as their basic comprehensive malaria control program. So 24 of the 40 malaria sub-Saharan African countries that Global Fund was funding in the last cycle did have funding gaps of more than $10 million for that 3-year period for their core malaria control program. So important gaps that are being seen. And then this one is just to look at in the vector control space specifically. So for funding gaps for the insecticide-treated nets that these countries need for their campaigns over this current grant cycle, so the 3 years which we're in the middle of now, there are 28 out of 52 countries which have got a funding gap for getting at least one net to every 2 people, actually, in their country. So those are the kind of pressures that countries are under. Should I invest in bolstering the efficiency of my HMIS system, or should I make sure that the people in that part of the country also get nets? You know, it really is tricky. And then when we have new WHO policy recommendations come out for exciting new tools that really could improve the impact that we're having on malaria and perhaps help us restart the progress against malaria, how do I fit them into my program when I don't have enough money even for the standard nets, and the new nets cost around $1 more? So in the last funding cycle, we did a review of what prioritization decisions were being taken and how. So first thing to point out is that it was evident that there wasn't a clear and consistent process to how country programs were making decisions. But I want to go straight to the but on that. But despite that, it does seem that the prioritization decisions were generally sound. Now, clearly, I'm going to talk about, and others have talked about, how we don't have enough information about what exactly are the correct and the most impactful prioritization decisions. But in terms of making sure the highest priority interventions and the core interventions as defined by WHO were met, then prioritization decisions were sound, and I'll talk about what they were in a minute. So here, how is the resolution on that? Can you read it? So I've split this into the middle column, which is the countries which are in a malaria control context, and the right-hand side column, which is the countries that are in pre-elimination or elimination context, because clearly there are different interventions you would prioritize in those settings. But this was the prioritization we saw in the countries we were funding in the last 3-year cycle. So public sector facility-based case management was #1 priority. Countries were making all efforts to ensure that the commodities and the basic implementation costs for that were covered before they would look at the next activity. The next priority is universal coverage for vector control. And those two things were basically seen as the underpinning absolute musts of a malaria control program before they would move on to looking at the other aspects. Severe malaria interventions was the next thing, and then you can see down the table as the different interventions came into play. Of course, there was variation between countries, but we saw quite a high level of consistency in terms of the level of prioritization given to these different interventions. But what's important to note is it's not a step-by-step process. So it isn't the case that countries are completely filling the budget needs for a certain intervention before going to the next priority one, before going to the next priority one. It was more a case of, you see that at the top 2 priority levels, so facility-based case management and basic vector control. And then beyond that, it seemed to be a case of funding some of most of the recommended interventions for their setting. There was a definite tendency to, for example, want to adopt any new intervention. So as soon as SMC became a WHO recommended intervention for those target countries, all of them wanted to include it at least in part. I mean, you know, there's a clear desire to start intervening or start introducing interventions that are known to be impactful in your setting, even if you can only do a bit of it. Then geographical targeting, we did see in some countries, geographical targeting to the highest burden areas of the country. But this was really seen much more in areas where the transmission is heterogeneous, so in the lower transmission settings, obviously, otherwise you wouldn't really have areas of higher transmission, and in the pre-elimination and elimination context. And that is important for many countries, but for large swathes of sub-Saharan Africa, it was not really something that was feasible or politically acceptable within the country when malaria was so bad throughout the country. And this is a key point which has come up in many of the other talks so far, especially from Damien, this issue that prioritization is influenced by so many factors. So yes, we can produce allocative efficiency models saying if you carefully combined IRS here and larva control here and ITNs here and severe malaria case management here, this is the perfect combination that would get you the best impact. That's not what guides the decisions. It's equity, so making sure that everyone in your country has access to the life-saving medication, for example. It's donor interest to a certain extent. There are certain interventions that you do see being rolled out more in countries that have focus from specific donors. Absolute cost seemed to be an issue as well. So, for example, lower cost interventions were much more likely lower absolute cost interventions were much more likely to be fully funded than before countries would start on another intervention that they might be able to only make a small impact on. So IPTP, for example, is pretty much fully funded everywhere. It's a very low-cost intervention. So even though it might not be as impactful as, say, spraying the whole highest burden area of your country, it's achievable. You can you can fulfill that intervention with no funding gap, and there's something to that. That was an attractive aspect. And then the issue of starting down and winding up interventions. So if you have already started an intervention in your country, even if you can't fully fund it, it tends to be continued. So and there are costs involved in that should also be taken into account. So there was a tendency to continue what had been started. and continue the pattern of prioritization. So the challenges that we're faced, guidance only goes so far. And as I said before, there is WHO guidance to an extent. There's guidance on what should be your core interventions and what should be your complementary interventions. But within the core interventions, there is little guidance in terms of how to prioritize for your country. And as I said, that is a necessary, in my opinion, lack of guidance at the moment, because there isn't the information on which to base that guidance. However, it doesn't mean that decisions don't have to be taken. And this is the critical piece of lack of information. So we don't really understand the comparative cost effectiveness of the interventions in different settings. And that is the main problem that is underpinning the use of allocative efficiency models in some settings. So it's useful to have these models that can inform discussion, but there are serious limitations about how far they can go, because the data that's going into those models is shaky in many cases. It generalizes estimates of impact which might not be applicable to many countries, and it also doesn't take into account insecticide resistance, for example. And further, these allocative efficiency models often give very specific guidance. So, for example, in one country we had advice that the most perfectly cost-effective malaria strategy would include 40% coverage with nets here and 65% coverage with nets here and 30% coverage with IRS. And that just doesn't translate into how somebody operationalizes a malaria control program. And then also, as Damien said, the factors affecting decision-making are really, really diverse, and it's quite evident that pure cost-effectiveness is not something that drives decisions in many cases. So the decisions that we're facing at the moment about when to support countries when they would like to use their funding to prioritize pyrethroid PBO nets. The WHO recommendations are that pyrethroid-only nets are still a recommended option for all places, that pyrethroid PBO nets are as good as the standard nets and likely better in specific insecticide resistance contexts, and that pyrethroid PBO nets should only be considered if this will not compromise universal coverage overall. So the question that countries are faced with, will I fit the right insecticide resistance context, so pyrethroid PBO nets might give me better control, but they do cost more. So should I buy some, or should I prioritize other gaps in my malaria control budget? So the decision-making process that we try to work through with them when they're getting ready to place their net order is, if you have any gaps in your net budget, then don't buy pyrethroid PBO nets, because they are costing more at the moment. You need to cover as many people as you can with the cheapest recommended tool. If you have a fully funded net budget and you have some flexibility around that, and you don't have any other gaps in your malaria budget, and despite the dire figures I did show earlier, there are quite a few countries that do have a malaria program with no budget gaps, then yes, buy as many pyrethroid PBO nets as you can and target them to the areas where the data show that you fit the insecticide resistance contexts. And if you have some flexibility in the LLAN budget that you have funded, but you have other gaps in your malaria control program, then clearly it's a lot more complicated. So it needs to become a much more pragmatic process of going through all the data that you have for your country, estimating what's the likely additional benefit you would get from the pyrethroid PBO nets based on only a moderate level of understanding by the malaria control community as to what that impact might be, and then have a stakeholder discussion on your gap prioritization and what decision to take. So those first two aspects, they're completely covered by the WHO guidance. They guide you to take those first two decisions. And the second one, as I said, there is no guidance to do that. And the reason there's no guidance is because we don't understand. We don't have the evidence that would be needed to inform that guidance. And as I said also, even though that guidance isn't there, because the evidence isn't there, it doesn't mean the decision goes away. So there's a lot of decisions that have to happen in the absence of perfect information. So the decision-making process that we go through with countries to try and work through this issue of deciding what kind of nets to buy, we summarize all the data they have available for their country to determine if they have the right insecticide resistance contexts, including looking at the mosquito populations to look at how you might extrapolate within the country. and then comment qualitatively, really, on that data and say, you know, how much reliance should you put on these data? How old are they? How new are they? How many data points do you have throughout the country? Are there any other data points in nearby countries you could use to give an indication about that side of the country? And then give the information to the country, basically, and say, well, this is what the data shows. Yes, you have, maybe I've gone too much into the details of the resistance there. You might have the insecticide resistance context that suggests that these nets will have a benefit in your setting, and it's seen in some of your mosquito vectors, but not all of your mosquito vectors, and just lay out all the information. And based on that, you can give the guidance that these tools might give you more impact, probably will give you more impact, or probably won't give you more impact. But that's the level of certainty with which countries are trying to make these decisions. And that's the information they have on the table when they have to make these hard decisions, such as, should I buy these tools or should I fund the gaps in my severe malaria medications? So I'm not providing many solutions here, but I'm trying to make clear how complicated it is at the moment and how it's not just a lack of data and it's not just a lack of guidance. It's a lack of the evidence bit in between that help us understand how to interpret the data into decision making, and that information is needed before there can be the guidance. We can't just call for guidance when there's no information on which to make the guidance. So just in conclusion, will prioritization lead to better impact? I think we see that in the high burden countries, any great effort that goes into developing evidence and prioritization guidance may end up leading to exactly the same decisions that are being taken now. So I think it's important to understand that prioritization may have an important role in many contexts, but in some contexts, prioritization decisions are being taken quite sensibly in the meantime. So it's not all dire. But in the realm of more expensive tools, in the realm of increasing insecticide resistance, then this prioritization, I think, will become more critical. And what would help to improve? So yes, more guidance. It's important, but it will always, WHO guidance will be at the global level, and there will always be a need for local level prioritization decision making, and I don't think that should be underestimated, the importance of that. More data, yes, and we've talked a lot about prevalence data, but entomological data is going to be critical. I'm a bit biased, I work in the vector control space, but critical going forward, and a lot of the new tools that are arising at the moment are in that space and have the potential to have a lot of impact. So understanding where to prioritize for the higher cost tools will be important there. But as I said, more data doesn't deal with the gap of understanding what to do with that data. And for that, we need more understanding of the impact of different tools in different settings. And I don't want to suggest that we need perfect information about that. There does need to be a balance between wanting local evidence and making it a bottleneck to making decisions, because as we see, decisions are being taken anyway. So it's good to have more information, but we don't need perfect information. And yes, there may be a role of modelling, and the more information we have about understanding the different impacts of interventions in different settings, I think the more modelling will start to play a more useful role. And lastly, more money would largely solve the prioritisation problem, because we really, and it's a little bit flippant, but it is important to remember that all malaria control interventions are highly cost effective, and it's depressing that we find ourselves in a situation of having to pick between these incredibly highly cost-effective interventions. But equally, the more money we have, the more important prioritization will become. As I said now, at the moment, many countries, they need to fund case management, they need to fund universal coverage for vector control, and beyond that, they can start thinking, okay, what will be more impactful? SMC or a bit of IRS here, what will be more impactful? But until we get to that stage, we're still at the case of, well, if I have more money, I'll just continue trying to buy my drugs. When you're at a certain level of funding, the prioritization decisions are obvious. I don't think I saved you any time, sorry. Thank you.
Brilliant. Oh my. Okay, so we've had perspectives now from the country level, some of the challenges on the ground, but also at the global level from the Global Financing Institution, one of the key players, one of the biggest players, actually probably the biggest player. Lots of issues there. I'm looking for hands, eager questions, clarifications, and I'm not seeing any. So let us move on to something that we've just started to hear a little bit about. You know, how do we balance all these complexities, all these different pressures when trying to prioritise allocation of scarce resources? So let's now welcome Francis Ruiz from Imperial College to talk about health technology assessments and their potential in malaria control.
So I'm in the fortunate or unfortunate position in that lots of the points that have been made, or I would like to make, have already been made. So, so this could be a very quick presentation, which is handy because I have rather a lot of slides and they're far too busy. But I'm going to take the starting point that what I'm really interested in is effective priority setting. Effective priority setting for UHC, and that means taking a position where you are relatively agnostic towards diseases and conditions and relatively agnostic towards interventions. The focus is on maximising population health, okay, subject to a whole range of value judgments that you may want to apply, not least among them issues of fairness. So this is going to be my starting point. I am going to use some malaria examples, but this is where I'm coming from. And we've got health systems, as we've just heard, under pressure everywhere. And policymakers are having to make very hard decisions, as we've heard, because of user expectations, because of growth in new technologies, expensive new technologies. They have finite budgets that they have to work with. There are perhaps donor expectations as well. That's all impinging on decision making. And even when there are sort of finite budgets and there is a claim or a legitimate claim for more money for health, there is still evidence that healthcare budgets are often underspent. Money is just not being absorbed for various reasons. It's just not getting through to actual practice. There's a real set of issues here. And indeed, WHO and others have estimated there's quite a lot of waste in healthcare. Quite a shocking amount of waste if you actually believe these figures. So there is real need to make the most of every dollar, every pound spent. And the problem is in LMIC settings where there is malaria, and you know, there are lots of priorities, lots of claims for money and support, and lots of people with very vocal opinions on the importance of these various disease areas. So lots of competing priorities often result in ad hoc resource allocation decisions and implicit rationing and so on and so forth. Even though it seems, at least in the case of malaria, reasonably sensible decisions are made in the absence of a sensible priority setting process. And it's perhaps in this space, it's not surprising you get a charity like GiveWell come along, which aims to provide information on most cost-effective choices that philanthropists can make. You know, if you've got buckets of cash and you want to spend it somewhere, this charity is there to give you the information, and they've made it very clear how cost-effective mosquito nets are. If only it was that simple, and sadly it isn't. Now, the data around costs and cost effectiveness is pretty poor, I think, in many of these settings. There are lots of variability here, but perhaps we could think about there are differences potentially in cost of control and cost of elimination. But arguably, as the burden of malaria diminishes, certainly reaching you know, areas where there's still sort of you know, disease and malaria can be very difficult as you try to get to the last mile. So the gains to be had as you move towards elimination become more difficult to achieve. And it might mean that actually when it comes to thinking through the cost effectiveness of malaria interventions, you can't adopt a one-size-fits-all. So depending on geography or depending on other factors, different interventions make sense in different settings and different circumstances. So what we do know, and this is sort of a recap from many of the presentations that have been made already, external aid is on the decline, there's man competition for limited resources, and I personally believe cost effectiveness has an important basis in informing resource allocation decisions. But when it comes to malaria, there is something to be said about the importance of geographic targeting. What we do know is as we move towards elimination, interventions can become less cost effective, so there's some imagination that's needed there. These are the important sort of starting points when we start to think through, well, what do we do next in terms of informing better priority-setting decisions? Well, a good starting point is actually to think about the WHO's own resolution on health technology assessment. I think it's one important way, or health technology assessment is one important way to maximise the health gain and make very difficult resource allocation decisions much more transparent and explicit. And it's important to point out you can only ever spend your dollar once or your pound once, so you need to do it as best as you possibly can. We know about the economic burden of malaria. I don't need to recap it for many of you here. And great progress has already been made, as you've already heard. But there are risks of reversal to those gains. And we also know that many interventions can be highly cost-effective. We've just heard Kate sort of articulate that very well. Of course, when they're used the right way and not as fishing nets or goalposts or whatever else. So it does matter. We've just heard earlier on the threat of insecticide and drug resistance and so on and so forth. And so this is becoming increasingly important. And we also know that new interventions to address those resistance problems are potentially more cost effective, but they're certainly more costly. So what do we do? We've just heard about parathyroid PBO nets. And the problem is we just don't have that much data. Data to identify the public health value of these nets is very limited indeed. And until about 2017, there wasn't really any clear guidance on what to do for countries. What should countries do in terms of these new technologies that have come about? We do have some sense of what outcomes may be important in terms of identifying the importance of next generation vector methods for public health. But it really hasn't become useful in terms of informing how we value some of these technologies. So criteria to be met to identify incremental effectiveness against resistant vectors and at what level the corresponding incremental cost is acceptable has not been identified or clarified by the WHO, and perhaps that's not its role, or the VCAGs. Currently, it's expected that the evidence base will continue to be relatively weak. UNITAID released a call for investment proposals to aim to sort of speed up the market entry of these new technologies, these next generation nets. But while well-intentioned, the initiative doesn't really address the comparative effectiveness, because that's what we really need to know, the comparative effectiveness of these technologies. And there really is no sort of established processes out there, certainly at the global level, that can help support these sort of assessments that are needed. Since 2017, costs and source of cost effectiveness data is now being encouraged by the vector control advisory groups. Although, and I could be wrong here, but the latest available guidance, the focus is very much on economies of scale rather than established comparative clinical and cost effectiveness. we've heard, well, there is an attempt to introduce catalytic funding, of course, where there's a sort of time-limited co-payment on that. But there really needs to be a bit more detail about how that would look like in order to stop perverse incentives. Signalling to manufacturers, for example, that there's enough funds in the market, irrespective of what the evidence is, to support their use. So there's a real need to shape up those conditional funding and catalytic funding initiatives as well. And this is perhaps one way of thinking through how we can better deal with that, is a sort of introducing, I don't know if it's very clear, but some sort of health technology assessment step in the process that can provide a feedback loop to really understand the comparative and clinical effectiveness of these technologies. I won't linger on this. This is just highlighting the fact that everyone is now getting concerned about value for money. Not just the Global Fund, everyone is doing so as well. And as I said, health technology assessment, I think, provides a useful framework within which to consider these sort of issues. So let's explain, or let me sort of say a little bit more about what I mean by that. Health technology is basically any sort of intervention that could be used to promote health, prevent disease, treat or acute or chronic disease. So it's a very varied concept. Commonly, HTA has been used to look at drugs only, but it can be used to consider health promotion activities, even sort of system configuration. Health technology assessment is a way of systematically evaluating the properties of a different set of technologies, taking into account not only the economic aspects and the clinical aspects, but also ethical and social value judgments as well. And in fact, it's probably helpful to consider or think about HTA as a sort of a 5-step process, where you start to think about, well, what is it that you need to address? What is your decision problem? Just defining the decision space. And then it's taking you through a series of analytical steps where you gather evidence, the best available evidence that you have, and then you take that evidence and trying to interpret it to make some sort of recommendations. Decision making will be done by a different group, and then the next step would be, well, now you've got a decision based on that evidence, based on that interpretation of all that evidence, applying value judgments and so on and so forth, getting it implemented. And this sounds all very simple, but it clearly isn't. So here's an example from malaria. You know, Minister of Health perhaps has been asked by the President whether they should introduce the malaria vaccine, for example, and for whom. They in turn asked the NMCP whether that would be a good idea or not. Some sort of technical analysis takes place, maybe with a budget impact analysis, with a cost effectiveness analysis. The NMCP or MOH could convene a panel to look at that evidence, make some recommendations, and the Ministry of Health, take those recommendations, make a decision, one hopes, greatly in line with the evidence, greatly in line with the recommendations, and then the NMCP are then given the responsibility by the MOH for implementing the decision. This is a potential way forward. One important problem when it comes to thinking about the cost effectiveness of malaria, indeed, you know, a whole variety of infectious diseases, is the quality of the modelling that goes into it. So there has been attempts in recent years to link infectious disease models to economic evaluations, but there is a diverse range, to say the least, of modelling methods, indicating very little standardization. It's going to be very challenged to actually interpret those findings. And many of the attempts in doing these kind of evaluations don't adhere necessarily to best practice, in terms, at least in terms of reporting anyway. So you need some sort of consistent framework when you think about the cost effectiveness of any technology, in fact. Doesn't matter whether it's to target malaria or not, because there is uncertainty. And if you don't have a framework within which you're going to look at these technologies, you're introducing another layer of uncertainty into the data, into the interpretation. So, of late, there's been an attempt to try and reduce methodological uncertainty, and in many countries of the world where they have well-established HTA systems, they have well-established reference cases. And a reference case is a key cornerstone of a robust set of methods, and it's a way of standardizing the analysis so that results are presented in a consistent way. Now, reference cases will differ by context. So here in the UK, NICE uses, NICE is the HTA, the priority setting agency here in the UK. NICE has its own highly prescriptive reference case, which sets out very clearly this is the sort of information we need to make decisions. And different countries will have their own versions of that, where they've instituted HTA. So there is no one-size-fits-all, but one can at least define a reference case based on a common set of principles that we've learned over many years of doing economic evaluations around the world. And one attempt to do that is embodied in this piece of work around the International Decision Support Initiative's reference case, where the emphasis is on supporting decision-making, not necessarily being prescriptive, and it's centered around a set of what one might regard as common sense principles. But sometimes common sense principles need to be set out in writing and articulated clearly. And here they are. I'm not going to go through all of them, but I'm just going to highlight a few things that I think are going to be important. One I think important aspect of this reference case, and indeed any reference case, it can help drive data collection, because the goal of this reference case is to collect information, interpret that information, and to take appropriate evaluations to serve decision making. So there's a heavy emphasis on decision relevant data. So first principle, communicating your economic evaluation in a transparent way, so to allow the decision maker to correctly interpret the methods and results. Seems obvious, commonly isn't done. Principle number 4, and this is perhaps contentious, the measure of health outcomes should be appropriate to the decision problem, and it should capture positive and negative effects on length of life and quality of life, and should be generalizable across disease states. What effectively that means, and there's really only 2 shows in town when it comes to that, is QALYs and DALYs. These are meaningful health outcome measures in the context of making resource allocation decisions, if you are concerned about trying to address issues of population health rather than taking a disease-specific approach. So, and having a generalizable health outcome is important when you think about making decisions about what is cost-effective. If you don't have a common currency, if you don't have a common benchmark, it's very difficult to know whether something is cost-effective or not. Important, principle number 8, important to characterize uncertainty. Decisions, as we've just heard, or heard in the previous presentation, will always be done under uncertainty, and there will never be perfect evidence, so it's important to characterize it appropriately. And the very last principle there, any economic evaluation should explore equity implications. So it's important to highlight that doing cost effectiveness, doing HTA does not mean that you ignore these kind of issues. What I think is important is to explore what the trade-offs are when you start to think about equity. What are the losses in terms of population health if you do feel from a fairness perspective that you need to target certain groups with special resources which as a result may mean that you're doing something that's not necessarily all that cost effective. But HTA won't answer everything. It's certainly no silver bullet. All sorts of questions there. The key point that I want to make is underneath, is at the bottom of that slide really. The effective use of HTA requires multidisciplinary working, getting your hands dirty, working with policymakers, and basically living with a very difficult political process, which I suppose is a good segue into the next presentation that's going to be coming your way. Thank you very much.
Thank you very much indeed. So I'm looking again for any pressing questions. Justin,
If I can ask one,
you're trying to stave off your talk coming up next. So, yeah, go ahead.
I think when I've seen HTA bodies established in countries, it's often at a ministerial level, and there might be questions about how feasible it is to integrate it into the nitty-gritty of planning that we've heard about today, especially with all the uncertainties, with the lack of the baseline metric of whether it's individual versus population. Have you seen examples where it's been integrated that way in a programmatic level for specific disease control or for similar sorts of issues?
Well, no, but I think there's an increasing desire to do so. But I mean, I think there's a real need to be thinking about HTA as not something that will address specific programmatic things, but actually has a utility that looks across the health system as a whole, especially as you move towards UHC. Now, we're seeing, certainly in sub-Saharan Africa, an increasing interest. There's a long way to go still, but increasing interest in using HTA, particularly in those countries that are transitioning from aid. And that's to go beyond sort of thinking about single disease areas, but to think about, well, what are we getting from the resources that we're spending? So, certainly from the perspective of some of the donors, some of the funders, I think, it's going to be important for them to start thinking through how best that they should prioritise, and perhaps there is value in applying sort of solid HTA principles to what they're doing. But I would strongly argue that I think what countries need to do is to establish HTA systems that sort of take you beyond, single diseases or conditions, and establish HTA bodies that seek to sort of maximise every dollar spent, whatever the health condition and disease area.
Thank you very much. Okay, so let's hold on further questions and discussion, either for the panel session, which I hope we'll still have time for, or during the reception. But let's move on now to, and I think it is, what we just heard is a good segue to Justin Parkhurst, now based at the London School of Economics, who's going to talk to us a little bit about the political economy of decision-making around malaria control. Justin.
Okay, thank you all very much. Good afternoon. I think so many of the things that I have in my slides here and that I was going to talk about have really been covered today, so I will try and be as quick as possible. I know we want to have time for more discussions beyond this. What I'm going to present really is kind of thinking that's currently going into two papers we're trying to develop, but I'm combining it into one presentation. One is about the use of evidence, and it's very similar to what Jane talked about, but from a slightly different perspective. And then the other is about decision-making, and again, many of the same concepts that we've already heard. And I think actually the Ugandan presentation in particular really illustrated the nitty-gritty of some of the challenges. To approach this, so I'm more of a political scientist. I say that with caveats because I'm at the LSE, which is the School of Economics and Political Science, and I don't actually have a political science degree, but I study public policy and policy making. I think what we've heard today, and I think it's fair to say, is that control of malaria is typically conceptualized in very technical terms as a public health issue, often the remit of epidemiologists and planners, and it involves, as we've seen today, the review of evidence, modeling, and decisions between combinations of interventions and strategies to control or even eliminate malaria. But realities may differ. So the previous speaker talked about being agnostic to the disease and agnostic to the intervention, and what we know is decision makers very rarely are agnostic to the disease and agnostic to the intervention. There are a range of concerns beyond technical decision-making for national stakeholders. In political science language, they talk about things such as bounded rationality that policymakers have to follow, things that bind our ability to choose, whether it's other priorities, whether it's lack of information, and so on, versus the comprehensive rationality that we often think goes behind technical decision-making. The very real importance of international aid and development finance, which has also, of course, been covered today. And local and bureaucratic politics don't go away in the face of a health issue, and I think some of that was already indeed highlighted as well. So we're trying to, in a sense, draw these themes out and understand, as I said, two things. One is the nature of evidence use for policy a bit more, and that's a field that I mostly work on, and I've worked on for many years now. And then the other is specifically decision-making for malaria. Very quickly, in a slide or two, I'll talk about the nature of evidence use for policy and how we've learned some lessons from this program. Ultimately, evidence use has many meanings. So this has been known actually for many decades. This is a paper from 1979 by Carol Weiss, The Many Meanings of Research Utilization, and a later book by Sandra Nutley and colleagues called Using Evidence. And it recognizes, and these works map out the fact that when we talk about using evidence, it can mean multiple things to multiple people. And sometimes we lose sight of that. Because the idea of evidence-informed policy is actually a very narrow and specific type of evidence use. And very often what we see is people talking about evidence use in terms of some kind of application of comparative effectiveness or cost-effectiveness analysis to inform a choice of interventions for an established goal. And that goal is usually assumed to be uncontested. Everyone agrees that's the goal. We just have to pick the appropriate intervention. And the medical model works very well. The evidence-based medicine model works very well, where the patient and the clinician both have the same goal in mind, improve the patient's health outcome. What's the most effective or cost-effective approach? Yet those works, which date back 30, 40 years now, mention that this is very actually rarely the combination of factors that we see in practice when it comes to actual policy making. And so how do we move forward? We know that there's a lot of ways, things that evidence use can mean, and this one technical form of evidence use actually is very rarely seen. How do we move forward and think about evidence use? So this is informing one paper we're trying to draw on from the LINK project, is to say, well, why don't we start by the perspective of a program? And in this case, we're starting from the perspective of national malaria control programs. And this is where it's approaching much of the same question that Jane was talking about in terms of the evidence you need and the evidence you have and so on, but approaching it from a different perspective. So I would say Jane's really talking about what we do with maps, what are maps good for? So here's a piece of evidence, how is it used? This perspective starts by saying, well, what are you trying to do, and which pieces of evidence are useful for that? And so we recognize we had workshops at the MIM conference, and many of the stakeholders in the room here, also the last couple of days were working with us. We recognize there are many key tasks that national malaria control programs do. And it's not just about allocating a budget, either between locations and interventions. NMCPs also have to advocate for budgets. They also have to do things like identify information needs and gaps. They have to plan for the future, and they have to write regulations and so on. And I won't go into too much time here, but basically what we can do is try and map out how evidence fits into the goals based around the starting point of what are NMCPs trying to do, what do they have to do. So there may be different relevant forms of evidence that inform each of those tasks. There might be more or less legitimate sources of evidence to inform those tasks. And one of the things that kind of came out from our discussions with stakeholders is that program officers in national malaria control programs also provide evidence. They're not just recipients at times. They have to provide evidence, for example, to their Ministry of Finance or to the Global Fund. So they have targets of evidence or to implementing partners. And what the use of evidence means is very much dictated by the task that they have to achieve. So there'll be useful features of evidence. So useful evidence for convincing the Ministry of Finance to increase the budget or to write into a Global Fund proposal is evidence that shows that there's a problem, but also perhaps evidence of competence. It shows that the NMCP is competent and high quality in the work they do. And that's a very different use of evidence to this kind of classic idea of using the evidence to weigh up between competing intervention strategies. I don't have time to go into all of these, and this is still kind of a work in progress, as I say. What about the political economy of malaria control, which is very linked to this? To understand that, I think we're approaching it by thinking about what's the nature of malaria decisions. What sorts of decisions are being made, which agency makes the decision, what stakeholders are involved, and how do we see interest playing out? And then ultimately, I'm more of an institutionalist in my approach. I'm interested in how structural factors will shape this as well, and how planning structures are oriented. So in the draft paper we're working on, I use kind of a classic public policy or policy sciences approach of looking at policy change by the influence of three areas: ideas, interests, and institutions. This is kind of a classic breakdown that you often see in the literature. Interests are probably the most obvious one. This is how key stakeholders pursue interests, and they have things that they're trying to achieve, and you might look for who has influence based on their interests. But we also know that ideas, in terms of dominant ways of thinking, agreed norms, goals that we're trying to pursue, those can influence policy decision. And institutions, the arrangements by which decisions are made, the processes which are followed for planning and decision making, institutionalized norms and regulations and the like. This will shape who has authority, who has influence over the decision making system. I'm thinking I'm going to have to go quickly because of the time. But really what we're seeing and what's really come out from our stakeholders is that we see what I'm kind of dividing for today into two key domains of politics. International domain, and what really stands out is this critical importance of donors and donor financing. So here are just some quotes from some of our key informants. A country cannot get to elimination without funding from outside. This is from DRC. You need sustainable funding at the country level. So this is a big issue for financing and funding that really drives decision making. And in malaria control, it is very, very dominated by international finance. Or someone in Malawi saying we need to invest more in behavior change, but a feeling that the Global Fund wouldn't prioritize that. Now, we've heard from the Global Fund, and that might not be necessarily totally accurate, or it might not be recognizing the different ways to work with the Global Fund, but these are perspectives that we see very often. We recognize that there's key global bodies play established institutionalized roles, the WHO playing a role of providing expertise, the Global Fund its financing, bilateral donors have broader development agendas but also provide aid and so on. But then we have domestic politics as well. And I have a note here that the domestic examples we were hearing are very, very context specific. Political will varies by country. So we heard in Uganda the president is currently meeting and talking about malaria. In other countries you might not have that level of interest or level of commitment. You have the internal politics of ministries of health and ministry of finance. We heard earlier today about data sharing, and one of the challenges is if within the Ministry of Health they want to share those data, or they're worried it will be they'll be stolen, for example. We had examples actually just yesterday, really good examples about how the electoral cycle can politicize interventions. So people not wanting to show their identity card to get a net around the time of an election because they're worried about how their identity is being used, or how at the time of an election, decision makers might spend more on nets because nets are visible while spraying is not very visible. So you could see very context-specific local politics as well playing out. Let's see, just moving right along. Here's a couple more quotes. In Malawi, there was this feeling that they had to lobby Parliament. Again, the domestic politics, lobby Parliament for more resources for malaria. That might be in a very different situation than if the president's actually sitting down and talking about malaria. At times, in the workshop we had, one person said at times, this is not an exact quote because we weren't recording it, but at times we need to advocate within country for broader health systems development, and then you'll see the malaria control program working with some of the other disease-specific programs in the country. Again, very context-specific on the domestic side, I'd say. So again, trying to apply this framework to the international politics, just a few examples. In terms of ideas, one of the ones that's been coming out a lot, universal coverage, how that as an idea shapes what we're doing as opposed to targeting and prioritizing. And I have another slide on that, which I won't spend too much time on because we've heard so much about it. Another example given in our workshop was about under fives, the idea of under five is a category that you want to address. And yet in one context, you might think we want to extend that age range. And so how just the idea of you target under fives might conflict with something you're trying to do on the ground. Interests, internationally. Again, we've heard all of this today. So the interests of donors, the interests of funding bodies. Examples that came out of our workshop, donors have already allocated an NGO or an international organization to undertake bed net distribution, and so that interest is already playing out, and it stops the NMCP from doing it. Agreements made with other countries without the NMCP's consultation, the interest of international organizations to do that, and so on. A DRC quote, when a partner arrives, he already has his budget and schedule, it's a little difficult to change. Now, it doesn't mean it's necessarily impossible. Obviously, there are these planning mechanisms, but we still see these themes coming out. And then ultimately what we see is, planning structures and review processes are fundamentally structures and systems through which various stakeholders have influence, and it institutionalizes influences in particular ways. A Ugandan quote here, there are a lot of management-related issues that come from the Global Fund and have implications on the ground. Now again, that's not necessarily saying that they're good or bad, but it's a recognition of the structures in place fix who has influence and whose systems are in place. There's also a lot of commonality, I think, in many of these. So you've got, it's a little bit blurry there, but this is Malaria Program Reviews Manual from the WHO, I think that's 2010. We see a lot of commonalities in kind of the structures and processes in terms of having a national malaria strategy, malaria program reviews, the roles of technical working groups as well. So at times we see institutional structures that influence planning and policymaking quite similar across our countries as well. I already gave a couple examples of domestic politics. Again, you can kind of break it down into how ideas play out. I gave that identity card example, how interests play out. Someone mentioned how local politicians will feel left out if their district is not being targeted, and that's pursuing their own political interest. And then you have domestic institutions as well. It was mentioned very clearly yesterday in our feedback workshop. NMCPs can differ. They can differ in their role in the Ministry of Health, their capacity, their authority, and so on. We've talked a lot today about targeting. It's a contested concept, but certainly it's come out in the interviews, and I think and our team has found that the idea of the use of maps rests on this assumption that it has to be targeted and tailored to specific areas, but there's this perception that it might undermine goals of universal access. Again, themes that have come up again a lot today, so I won't spend much time on it. And we can think about where this comes from. The previous section I talked about the evidence use. This is multiple goals of NMCPs to allocate resources but also to advocate. And you might need to use this universal idea to advocate for resources, but you need to target in order to allocate your resources. And these can be driven also by ideas, global ideas, scale up for impact from the rollback malaria ideas and so on. We can think about, and again, what's appropriate to pursue? How do ideas get set that might affect our planning and decision making? A number of planning challenges. This is less on the politics side. I think, again, we've heard many examples of this, so I'll skip through it quickly. Concerns at times were being raised about things like how do we incorporate local specifics into plans, gaps in data for planning, gaps about the private sector, and inability to take on the private, to the bottom-up perspectives. Just a Ghanaian interview here talking about private facilities have different reasons why they're not providing information to DHIMS. It's a challenge to get a composite health data. We need that public and private data. There might be lack of structures. This is, again, the institutional lens. Are there structures in place to feed back from the bottom-up perspectives? It can be very country-specific, so we have two contrasting quotes here, one from Ghana, struggling about the logistics to get needed information about whether your bed nets in a local area might be exhausted. You don't have the system in place to feed that up. In Kenya, on the other hand, as we heard actually earlier, a lot of it is decentralized. And so this quote from Kenya really talks about how the local systems, the local governments have to have their own systems, and the top level can't force them to prioritize one or another. I'm going to skip through this just in the interest of time. So just to summarize, data for decision making is a form of evidence use, but evidence use takes many forms in decisions, and I think that's dictated by the logics of the administration itself. So the logic we have, and the LINK project might have in terms of the theory of change, that if you provide this type of evidence, it should improve these types of decisions, is one logic. But national malaria control programs are bound by the logics of their jobs. It's bound by the goals that they're institutionally meant to pursue. And so that will mean pieces of evidence are used in different ways, and different forms of evidence will be more helpful. The political economy of malaria control revolves heavily around funding-related decisions. I think that's unsurprising. Stakeholders and structures, but this can manifest itself in different ways, in terms of ideas and how they get shaped, in terms of how stakeholders pursue interests, but also in how institutional structures work. International and domestic politics both matter, but I think in very different ways, and I think we're more likely to see shared commonalities in terms of how international structures, WHO rules or guidelines and norms, those are commonly factors that countries have to deal with. Domestic concerns much more variable. Data decision-making ultimately represents a technical element of a complex technical and political system. Hopefully that's not a surprise at all after all of today's presentations. But the technical elements are still central and still key. It doesn't mean technical decision-making doesn't matter. It doesn't mean technical data don't matter. It's just that they're embedded within domestic and international realities affecting how they play out. So I will end it there and say thank you. Thank you to you all for coming and attending, but thank you also very much to all of the stakeholders, all the interviewees, all the workshop participants who fed back to us, and finally thank you to our team, who Jane also started to mention. Carrie put up the slide with the names. Ludovica's name was mentioned, who did a fantastic amount of work in organizing and doing many of these interviews, but the rest of the team as well who are dotted around here, so thank you all.
So, excellent. Thank you very much. A bewildering amount of information that we've been absorbing, I hope, to a large extent since 1:30 when we first sat down. My terrible timekeeping has meant that we have a situation now where it's kind of, 20 to 5. We were supposed to be finishing at 5 o'clock with a reception. We're actually timetabled to be having a break now. But what I would propose is that actually we move straight on into the panel discussion, if that's okay, so that we can actually have some discussion as a plenary before then we go into the drinks reception. And I see various people nodding, so I think that's great. So in that case, can I invite Justin to come up here? I understand Carrie Lynch will also join us. Damien, if you could also join us at the front. Kate and Francis. And then we are going to, I'm going to hand over, I'm going to sit down as well, and hand over to Rita and Zhao, who I know has been trying to keep track of some of the key issues that have been coming up, and give us a chance, give you a chance to share some of your thoughts, some of your concerns maybe, some of your observations with us in the 40 minutes or so, well, it's supposed to be 20 minutes, but I'm sure we can go on a little bit longer that we've got available. So Rita, let me welcome you up here.
Thank you very much, David. We've had about 7 presentations this afternoon, and I've got the daunting task of, just bringing out the themes, and I'm going to try and be as succinct as possible, but we've been having amazing presentations, and thank you for all the presenters. With Carolyn, we see that we are having some definitions around targeting. She, of course, went around looking at the overall program itself and what it really entailed. In terms of prioritization, optimization of interventions, rationalizations, targeting interventions in accordance to epidemiological strata. And she also looked at the challenges in terms of data sharing, timelines, and how and when to target. And then when we come to Imelda's presentation, we can say that she also looked at thresholds at country level, specifically when it comes to the maps that were being drawn out. And in terms of capacity building, in order to have continuity and sustainability, there's a web-based application which has been brought out. The use of routine data in areas where transmission is low, incomplete public health facility, the utilization. And then she also talked about scaling back interventions, the need of guidance for a rational approach to guide the interventions in the area of scarce resources. In the third presentation, Jane looked at prioritization of an intervention or type of intervention. Again, she had a definition of targeting geographical areas of population subgroups, the delivery of an intervention. And then she also looked at incidence data as not being used for defining strategies. And there's not much of the use of maps for developing the national strategic plans. She also mentioned the information that you have is not what you want, and the information you want is not what you need. And the information that you want may not necessarily be where you're going to get it. It's not evident where you're going to get it. The information that they need is not what they can obtain. Is what she ended up with this very nice framework. So sometimes the information is not trusted because it's not understood. She actually explained that very well. For the Ugandan context, processes used in decision-making in Uganda at the country level. So this was being brought at the country context and the complexities around using data at the country context. So the determinants of decision-making using the WHO 6 principle health systems model was also explained. And he looked at the differences in policy making at the different levels, whether it's the Minister of Health, whether it's the communities. At different levels, you have different contexts in decision-making. And he also contextualized about the recommendations, the effective deployment of interventions. Kate from the Global Fund gave us pragmatic decisions by countries in terms of there's a finite or transition period that countries need to go through, especially when they're moving from high burden to very low endemicity, and whether to remove interventions, scale down, for example, IPT. It's not explicit in the WHO guidelines, although you have the broader guidance, but then the nitty-gritty when it comes to the ground level, again, needs to be contextualized at the country level. There's no clear prioritization process. It's a bit blurred when it comes to the transition period there. She also looked at the influences to the decision, the equity, the donor interest, absolute cost and acceptance issues. She also mentioned the lack of comparative cost effectiveness of interventions, which is not enough. And there's lack of insecticide resistance, and sometimes the data is quite shaky. When it comes to Francis, the health technology assessment, the need for priority setting, he mentioned that there's waste in healthcare globally, that is by WHO assessments. Economies of scale are more important than the cost effectiveness itself. He talked about catalytic funding and that there's little standardization in modeling. However, HTA is trying to solve this problem by standardizing in a manner where you can compare across studies. And then lastly, Justin, the political economy of using data for decision making, wrapped it up by saying that evidence is there, and evidence-informed policy is what we're looking at. However, the technical evidence is embedded by contextual political factors which actually shape the technical information that is available. And then he also mentioned about the international and domestic politics, which are both critical and have got their own complexities. And I'd like to say that in all this, we've seen that each angle is like a jigsaw puzzle, and each one fits in a certain area. Bringing it up all together, the impact is at the country level. So the economies of scale that we're looking at, are they as important as saving that child at the end of at the end of the road of the continuum? What we need is to save a child's life. Yes, the economies of scale need to be looked at, but what is the eminent issues that we need to focus on when you're at the country level? As Damien was saying, there's so many issues that you need to grapple with. And then there's increased diversity in transmission at a country, which demands optimization of interventions for impact as malaria becomes more granular. And data will guide NMCPs to a place where the interventions need to be maximized. So data is important, and hence the global technical strategy has actually guided countries to elevate to elevate monitoring, evaluation, and surveillance as a key strategy or core strategy in their programs. Having said that, I'd like to open now the floor for questions, for comments to our presenters so that we can move on. You're welcome. Yes. Any icebreakers? Yes, please.
Yes, I have a question for Kate.
You spoke about the scarcity of data available to inform decisions on allocations. I was wondering whether you think there's an opportunity there to leverage the interactions that the Global Fund has with countries to help us better understand how the same interventions cost different things to implement in different places.
Shall I go?
Go ahead.
I think in some ways there is enough data. In some areas there are enough data, in some areas data are scarce. So I think a particular area where data are scarce is on the side of the entomology. That's something that we are trying to look at the moment, discussing with GMP and looking at how our funding and our responsibility to be stewards to that funding can encourage the activity of entomological data collecting at country level. So that's a specific area we are looking at trying to help on building up the data for decision making there. But the other point I was trying to make was even when we do have sufficient data available, it's the lack of understanding how to interpret that data. I think that's what you're also getting at. So yes, we are also looking at how the Global Fund can help support the process of building that evidence around comparative cost effectiveness. And actually something that Francis pointed out was the UNITAID call for the fund that will support rollout at pilot scale of next generation insecticide treated nets. And that's something we're partnering with UNITAID on. And actually, we should probably have a chat because the underpinning rationale and point for that project is to develop comparative cost-effectiveness data, looking at how the new insecticide-treated nets, which don't yet have a policy recommendation, how they compare in terms of comparative effectiveness to the pyrethroid PBO nets and to the standard nets, so that once there's a WHO policy recommendation to allow scale-up of that product, we will have the information to help countries decide whether to invest in them or not. So that's sort of the rationale behind that kind of project. But that is something that goes quite far away from where the Global Fund normally sits in this space, which is really providing funding to have countries roll out evidence-based interventions. But there are, as you point out, gaps in the information, in data, and the Global Fund sees that there is a role that we can play in some areas to try and nudge that forward a bit. So it's just trying to find the right balance.
So Kate, if I could just jump in at that point. So what are you doing to ensure the data is going to be collected, all right? That's going to be useful. It's going to be useful evidence to demonstrate comparative clinical cost effectiveness. And what conditionalities are going to be put in place? Because of course, there is this commitment that these technologies are being funded. What if they don't turn out to be as cost effective?
Yeah.
As a result.
So I'd say that we are buying some of them under pilot conditions, but I wouldn't say we were funding them at whole scale at the moment because we don't have that information yet. So the way we're ensuring it's happening is that we're paying someone to do it because we are a financing organisation. So we have an evaluation partner, Path, who I think are streaming, hello Path, who will be putting in an evaluation framework in 4 different epidemiological contexts in sub-Saharan Africa. So we have selected a West African, a Central African, an East African, and Southern African context to pilot these new nets. And they will be deployed in a pilot area in the country with comparator districts, which will get either standard nets or pyrethroid PBO nets. And the incidence data will be used to generate the to understand the comparative cost effectiveness. Cost data will also be collected, evidently, to allow that.
Right.
So there is an evaluation framework around it, and the point is that this is a pilot intervention built specifically to develop that evidence, and that there is a co-payment that happens at the moment, and you pointed out the issue of that. And the idea of co-paying this product at the moment is that because we don't yet understand the justification for paying more for this tool, because it doesn't yet have the evidence and the policy recommendation, we can't put the burden on the country programs and their budgets to have to pay for these tools. Yet still we need the evidence. So using separate money, we can pay the co-payment with the understanding with the manufacturer that this is whilst we generate the evidence, and after that, the information that we find will be used to renegotiate the price.
Thank you very much.
That's the rationale.
Thank you. Yes, Joe?
So one of the interesting things here is about scale, because we don't, I think, expect the relative cost effectiveness of those new products to be the same in different places. It's going to be conditional on the resistance in those areas. So how we bring all that information, so the complex information about what's going on the ground, as well as the complex information on the properties and the relative properties of the alternative products, that's a very big contingency table that we're not going to get data to fill each of those cells. And it takes us back to the modelling that Francis talked about in the first place, and how we do that. I wanted to ask a more general question for everybody, because we've talked about the issue of scale from national downwards and the level of granularity that different decisions need. I wondered if there are decisions that go between countries, that are actually across countries, that are for countries essentially external goods. So some of those trials that you're talking about, they're for lots of different countries, including ones other than the places where the trials will happen. And how we do that generalization, who's thinking about those trans-country decisions and interests, particularly for resistance management. So I get to that point by asking, okay, cost effectiveness is part of the information we need in order to win the resistance arms race. But cost effectiveness and winning the arms race, they're slightly different. One is a bit bigger than the other. And I don't see anybody strategizing at that big, how do we win the resistance arms race level.
Thank you. Who'd like to take that?
Surely the authority for that lies.
Yeah, well, as usual with Joe's questions, there's no straightforward answer, and probably not an answer that everybody would agree with. But it sort of raises a couple of issues that have come up during the course of the afternoon. The lack of adequate evidence to inform solid guidance. WHO prides itself on being a knowledge-based organisation, but as Kate eloquently pointed out, in the absence of the evidence, decisions still have to be taken. And there is a current sort of gaping absence of guidance from WHO on how to go about taking decisions in the absence of evidence and in the absence of guidance. This is increasingly recognised. Our new Director General, who's been with us for over a year, has really focused attention on the need to provide countries with the support that they need to have impact. So we, as the Malaria Programme, as other departments are under pressure to make sure that we do a better job of coming up with guidance which will help countries to decide what sorts of interventions they should be prioritising. Having said that, it was brilliant for me to hear several of the speakers at various points that were being made. We understand the complexity a little bit better of decision-making at country level, but we understand from the review that Kate mentioned that actually the approaches that are generally being used are pretty rational. So, coming back to your question, I think we have to have a multi-pronged approach to generate information which we can turn into evidence and guidance. The funding of studies which Kate's just explained with Global Fund Unitaid co-financing to generate evidence of relative cost effectiveness of interventions and strategies. That's really key. But we can't do all the randomised controlled evaluations that we would want to do to be able to understand the relative cost effectiveness of different alternative strategies in every different scenario. So then we're going to come back to the role of modelling. And here there's going to be a tension. There's the challenge of understanding the 4 or 5 big, well-developed, mathematically complex models which exist. Questions can be posed to those modelling groups, and the answers need to be digested by people who have an understanding of this to try to inform global level guidance. But I don't think we can look to these complicated models to inform very local decision making, very specific challenges which some of the people I'm looking at directly here have to face in reality. We heard from Jane about the importance of data being intelligible, useful, but trusted, and that modelling the product, the outputs of some sort of black box modelling program are not necessarily going to be accepted to guide strategies at the country level. But no doubt there is some sort of role for modelling at country level, global level. And then I think the sort of third element to generating the understanding that we can start to have about prioritisation of interventions will come from doing a better job of tracking not only progress with malaria control and how disease burden changes, but setting that into the context of really granular information on the level, the coverage of different interventions, which strategies were deployed, so that as time goes forward, having deliberately, prospectively collated information, a district medical officer, regional medical officer, a malaria control program manager can look up in a database of different scenarios, something that approximates to the setting that he or she is primarily concerned with, and see, well, what has been tried in different settings and what has the outcome been. So that's not randomized controlled trial, that's not the highest grade of evidence, but it's a potential way forward to increase the confidence we can have when deciding to prioritise one interventional strategy over another.
It's what we did in the past when we introduced neurosensitize for spraying 40 years ago.
Reinventing the wheel.
Thank you. Anybody else wants to answer to that question? Oh, you're okay. Another question? Yes, please.
I thank all the presenters. Daniel from Kampala, Uganda. You've mentioned about data and need for data, like Francis and Justin mentioned that when there is not enough evidence, even a good idea from somebody powerful like the head of state, you justify whatever evidence it is to make a decision. Yet when some people collect information, then we say we don't have enough evidence to make the decision, like for the PBO nets. They've been here, we know the mechanism of their actions, we know that they are beyond the normal barrier, but we still delay the decisions just because we want more evidence. So when is evidence enough to make good decision?
Thank you for that. Anybody would like to take that up? Panelists?
Do you want me to kick off on that one? And then let's see where that goes. It's a very hard question, actually. And I think we've got to recognise that even what I was talking about, which is a means of incrementally improving the decision-making process, so ensuring that evidence gets into decisions, so there's much more rational priority setting. Ultimately, we're talking about establishing mechanisms which are effectively political, and I don't have a problem with that, right, because that's the real world. So when I talk about HTA, I talk about the need for locally legitimate, institutionalized structures for getting evidence into policy. And ideally, you'd want that to involve certain key principles, transparency, the use of the best available evidence, that's RCTs and non-RCT data. You want stakeholder engagement. You want some sort of transparent application of local values into that. But ultimately, there is going to be a certain degree of what's known as satisficing, essentially managing stakeholder vested interests, right? So there is not going to be it's never going to be perfect, right? But we're talking about sort of incremental improvements in the decision-making process. So evidence will never be perfect. It'll always be flawed in some ways. We should aim to collect the most relevant data, and the most relevant data should be that which is important for decision making, not necessarily important for research purposes per se. There may be some alignment, but not always. What may be interesting to a researcher may not be necessarily what's really needed for a policymaker. A reference case would be helpful in that regard, but we just need to recognise that we have to live with imperfections and getting your hands dirty. So that's my start for town.
Thank you, Francis. Anybody else, panelists? Yes, please.
I quite like, I would just say I really like Francis' answer on that when he pointed out the importance of principles. And my view when I look at, I've studied kind of systems of evidence use, not necessarily for malaria, but for health in general. And I think very rarely do we make the principles of evidence use as explicit as we need to. And so principles like transparency, as you mentioned, the best available evidence, quality, there are multiple principles with multiple normative values behind them. Some have to do with scientific good practice, right? So quality, rigor, being systematic, contestability perhaps from a peer review perspective, those are scientific principles of what is good evidence for decision making, appropriate to your question. There are also democratic principles that are needed to legitimate the system. For the system to be accepted, it has to be seen as a legitimate system. And so transparency, stakeholder consultation, authority for decisions lying in ideally someone who has a mandate to make those decisions. So it's not a pure technocratic decision. People will reject it, even if scientifically valid. Yeah. It can be rejected if it's done by people who don't have a mandate to do so. So there are also democratic principles at stake. And I don't think we do enough to first map out our principles as to what the system of evidence use should look like. Because you're absolutely right, there will be gaps and when there are gaps, it opens up more space for people to contest and to try and bring their own interests to hand. But if you have clearer principles on, when is something a value-based decision, when is something a technical decision, when you have a gap, who's, the most appropriate person to take that, I think it can, as you said, I really also like the language of incrementally change. You're not going to, institutions are complicated and government bureaucracies change incrementally, but the incremental change has to be guided by your principles. So making those principles explicit, I think, is really key.
Thank you very much. Yes, please.
Hi, I work for the Department for International Development, thanks. I work for the Department for International Development, and this question is mainly directed to Damien and Justin. What do you think are the key practical things that donors and technical agencies can do to maximise the chances of data and evidence being used to drive decision making?
Thank you. You want to start, Damien? Yes, go ahead.
From the side of because as I mentioned, the decision making is at the various levels, and it's very important that the donors have this perspective that it is not just the National Malaria Control Program making the decision. That it is important that if you're making a decision, you have different players, the political players, the community players, to whose pressure the political players respond to. And if the decision is not at all well communicated to all these players, it might not hold the ground. So in all these engagements, that there is not just engagement of programs, but engagement is beyond the support for the programs, is beyond the programs themselves. That's one thing, but also during the processes of the implementation, accountability, throughout all these various institutions are engaged, and also and if there are clear challenges or gaps that they see will impact the decision making, they are brought out and discussed openly. That the programs themselves might not feel free or easily express to themselves, that the donors can actively engage the political leaders. Sometimes they need that extra support.
Thank you very much, Damien. You want to answer, Francis?
No, just to me.
Although I do have comments.
Sorry, it was Justin. Go ahead, Justin.
Okay, just looking at the time. It's a big question. I think the international donor community actually has been pretty good in some ways over the last decade in emphasizing evidence and evaluation and being more rigorous about how funds are spent, but how aid money is used. DFID is one of the few funders who've also put money towards, there's the BCure project, the Building Capacity to Use Research Evidence, which has funded some groups to try and actually build systems and structures or capacity. The funding proposal that DFID rejected of mine for that project, with Calypso, I should say, talkative at IDSI. Sorry. And we're not bitter. What we proposed, and probably not clear enough in that proposal, but I think would be very useful for donors, is to facilitate processes by which countries can learn from each other about how to improve systems. So I mentioned earlier I don't have a political science degree necessarily. I have an international development background and social policy background. And if you come from an international development studies degree background, you're very sensitive towards top-down, outside imposed, even outside imposed ideas like you should be more evidence-based. But what we find, around this room, you have loads of people who are genuinely committed to making better decisions and more evidence-informed decisions. And so I think donors can really draw on that and tap that by spending funds to support peer learning between stakeholders like these, who can learn from each other about how to improve their systems. Because I think there is a shared goal to better use data and evidence. And there will be different experiences on how Sierra Leone or Kenya or Uganda or Ghana or any of the other countries that maybe were not part of LINC, how they have built their systems. I think you could facilitate discussions like what are the principles of good evidence use, but without dictating what those principles are. You can ask people what is good evidence use in your context, and then how have you achieved that? Has anyone else been able to achieve similar principles elsewhere? So I'd like to see it moving a bit towards a facilitation of peer learning process, again with that explicit concern with principles of good evidence use and getting people to share their experiences.
Thank you. Yes, Lisha Lala.
So I'm Lisha and I'm from DFID as well. So we've funded this programme for 5 years with some really good progress at MEND, LINC and WHO AFRO progress made. Just on Justin's point about peer-to-peer learning, some of the work of WHO AFRO has to ensure that sort of convening of different NMCPs to learn from each other. So I hope that carries on, and also through the new strategy WHO. I wanted to ask 2 short questions. So I really wanted to pick up on, in fact, obviously, we're coming to the conclusion of this data, it's really important to use it. GMP, I just wanted to understand how GMP plans to sort of sustain sort of the capacity to be able to do this as part of the 10+1 strategy, but also a bigger issue in terms of this whole sort of data governance issue, the accessibility of data. So I have a little fear that, whilst countries have signed up to open data initiatives, there is some sort of locking down of accessibility of data. Some governments are limiting access to data. So it's slightly political, but how are we sort of going to be able to move forward in this sort of context?
Thank you. Over to you, David.
Okay. Well, I can certainly start to talk about some of that, but it would be quite good to also hear some views from the floor of this, because clearly there's some experience and views there. So I see your comment on the peer-to-peer learning, sort of building on what Justin has said. At WHO, the malaria programme, we've been engaged in a review of policy-making process over the last 4 or 5 months now, which has been fascinating and very far-reaching and huge learning experience on many different levels. The engagement has actually included discussions with stakeholders, broad stakeholders, including some donor agencies, but also including at country level, endemic countries, malaria control programs in particular. And one of the things we heard very loud and clear was a demand for more opportunities for malaria program staff to be able to interact with other malaria programs staff. And I think this is a cry which came through crystal clear. But at the moment, it's not clear to me what are the sort of opportunities for that. So it's, Justin mentions it, we hear it from the programme managers, but once again, we're going to have to think about how that gets resourced. So you asked about GMP and the potential of the malaria program to sustain the capacity that's being developed here. I think I mentioned it, and Carrie also mentioned the way that we've learnt an awful lot through the LINK program. And actually, before the LINK program, there was a phase 1 period where the geostatistical methodology was applied to generate the epidemiological profiles. And very quickly it was realized that there's a need for additional input and support to try to communicate the meaning of the epidemiological profiles. And so that's why I think the London School part of the program got involved. And I think during the course of the LINK program, and we've heard it repeatedly this afternoon, one of the challenges to be able to move forward and sort of make decisions based on the evidence is the lack of guidance about how that evidence should be used. So in terms of the capacity to make decisions, well, I think we've heard in terms of the technical dimensions. Imelda told us about the application, which will enable countries to be able to access the outputs of the models, which at the start of the program were requiring not quite mainframe computers, but significant computing capacity, but things have moved on a bit. So that's a sort of technological, methodological innovation that LINK has been able to support. And so I think we're not so much concerned maybe about the sort of technical capacity to produce the maps. We're more concerned now about the guidance about what should happen depending on the output of the stratification efforts. And as part of this so-called 10+1 initiative, it's really, I heard it described as a problem statement. It's 10+1. So 10 refers to the 10 countries in Africa, and the 1 is India, which contribute between them over 70% of the global burden of malaria disease and death. And a need to, having had the wake-up call almost a year ago, refocus our efforts and our attention to these high-burden countries. And as part of that, there is an analytical framework which is being developed. It's pretty advanced now. It has been discussed amongst some of the partners to bring together the data which is expected to be needed to inform local decision-making practices. So it's very good to hear about the reference case and the way that HTA has a reference case, and to recognise that the data that is going to be needed in one setting is likely to be different from the data that's needed in another setting. So I think we're committed now within the Global Malaria Programme to developing this analytical approach which can be used at country level to generate in-depth understanding of the malaria situation, but also the context, other health system parameters, so that if the majority of care seeking is in the informal private sector, then we need to be able to consider that. But also the broader political context, the ethical issues and legal considerations. I think this is all now on the table in terms of information that is needed to inform decision making. So I think to try to wrap up, the malaria programme at WHO is keen to build on the experience of the LINK programme to take the next steps forward to support in an incremental way improvements in the way that decisions are taken at country level and also indeed at the global level.
Thank you very much, David. One more question? Yes, please, so that we can wrap up.
Yeah, thank you very much. I like Caroline, your statement about mosquito larvae, getting information, continuous information. I'm thinking of when the surrounding water is now becoming turbulent, when there is no convenience for the mosquito larvae to collect information, and all the water-related organisms start to know that there is problem. I'm bringing this one because somebody asked me during our Ebola outbreak, a lady from the community asked, if people are now talking about Ebola alone, where's malaria? This simply, I thought, okay, I think the whole information about malaria we have been passing to the community is being lost. And we know information for mapping, be it prevalence or mapping information we need in order to create those maps. And you know how long the Ebola episode actually existed, and we lost a lot of information. In the creation of those maps, what do we do in that case? Do we continue to give the map? It's going to be continuous work.
Karen, over to you.
So your question is, in the case where there's problems, what do you continue to collect data? I think that was my point. I think there's a need to institutionalize the collection and the ongoing collation of data so that in turbulent times it remains an ongoing process. But I think to do that requires specific personnel assigned to that data management and collation process. I know that some of our partners here discussed having a portal with an assigned person to allow them to institutionalize the data. And by that I mean have data retained to be used going forward, so you've got an historical kind of build-up of that data, rather than someone like us coming in every few years as a project trying to suddenly gather everything together on behalf of the National Malaria Control Programme. I think the issue with that is that it's a soft piece of an intervention. It's not a life-saving intervention. It's not a mosquito net. It's not treatment. And it suffers the same fate, I think, perhaps, as behaviour change communication interventions, that softer side, behavioural change side of things within a health system. That is more, I'll say, fluffy and more challenging to get to because it's not a hard, tangible piece of software that you can distribute to someone. But I think that it needs to be prioritised more. And what's tricky is to find the space and the funders and the Ministry of Health, the Ministry of Health's own prioritisation for that as well. Because that feeds back into that data sharing issue that Leisha spoke about as well, and where data is valuable, almost like money, then it is highly sensitive to both collect and then to house and keep. And perhaps during the reception afterwards, our colleagues from various countries can give some of your experiences to Leisha, or explain some of your experiences to Leisha in terms of that sensitivity at the country level. So I think, yeah, to steady ourselves through turbulent waters, we need to bolster data collation and make it more of a tangible thing.
Thank you very much, Carol. You want to add something before we wrap up?
If that's, I mean, I think so the first project I ever worked on after finishing my doctorate was DFID funded. Thank you very much, Tim. And it was on health systems and health systems development. And for me, that's why systems are so important, right? Systems, when they're robust, respond to crises. It's not just about individual interventions for individual diseases, because there will be crises, there will be outbreaks, there will be natural disasters, and a robust system, whether it's a part of data collection, human resources, and the like, will be able to respond better. Doesn't mean it's going to respond to everything, and of course you could be past your possible resource limit, but it will be a better, better integrated, a better, developed system will be able to respond, and we'll be able to shift data collection strategies across priority areas, we'll be able to shift back and so on. So I think it's kind of that lesson is one about health systems for me.
I think that's absolutely right, and I think that sort of speaks to this broader issue of the importance of health information systems, right? Let's go beyond the particulars of malaria, and this is specifically a health system strengthening thing, which will have an impact across a range of diseases. So it's not given the attention it deserves, I think.
Thank you very much to our panelists. A big hand of applause to them. Thank you so much. I'd like to hand it over back to David. David, over to you.
Well, I think from my side, I should hand it over to Carrie, who's carried the programme for the last few years, for any closing words. Carrie?
I would just say thank you so much to all of you for attending. Also very much to DFID, UK Aid, who supported the programme, but most especially to our National Malaria Control Programme colleagues and our evaluation team that worked with us at the country level for being with us for the whole programme, for working with us and for listening to us and also speaking to us and sharing your views. We thank you very, very much.